common muscle involved to be infiltrated with fat, sir, and it is the most primary stabilizer of paraspinal musculature, sir.
That's one. Second thing is, usually disc prolapse occurs only at one or two places.
Yes,
It doesn't occur the whole two.
Yes.
Whereas spinal stones can occur from top to bottom.
Yes.
What was your finding in this?
In cases of lumbar canal stenosis, irrespective of any segments affecting, sir, like L5S1 was the main segment which had more fat infiltration, sir, compared to other levels.
Then do you think that which is primary? Which is primary and which is secondary to you? According to your findings,
Yes, sir.
which is primary thing? Is it the disease proper, or this is the first thing to come and then that occurs?
So both has negative relationship between two, sir. Like one presides over the other and other presides over the other legs.
Right.
It has negative significant relationship.
Dr. Prajwal, what is the significance of your study?
So like,
How it is going to change the treatment modality of
Yes.
underlying pathology?
So like during pre-operative evaluation, if we do like complete evaluation of paraspinal musculofacial
No, not
structures-
like that. Let the multiplex infiltrate total with the fat. We have got a grade 2 listhesis, grade 1 listhesis. We have gotten disc prolapse indicated for surgery.
Yes.
Like that, how it is significant of your study
and we
to
can
management of underlying pathology?
like we can explain the patient about the prognosis and surgical outcomes.
No,
like,
do you think this is going to change the prognosis, change the protocol of your underlying pathology to treat spine pathologies?
like surgical outcome can be given, sir. Like usually we in our study we found out like patients with less infiltration had good prognosis and good post-operative symptom-free, sir. And recently we operated one grade 4 infiltration case, sir. With post-operatively she complained of severe pain and.
You mean to say grade 4 you are not going to operate then?
No, sir. Like we can.
No, answer to this. It is highly infiltrated, no muscle fiber, everything is fat. You will stop operating.
Pre-operatively we'll.
Now you know the result according to you. It's bad prognosis. You operate or not
If
operate?
time permits, we can do strengthening of paraspinal muscles.
Sir, anything, sir?
This is purely a statistical analysis.
Yes.
What sir was asking, and also my doubt is, by looking at that particular infiltration,
Yes.
can we say anything to the patient? Yes, there is a lot of infiltration. Yes, go for this. There is less infiltration. Go for that. Can you just by looking at your all these particular statistics, can we say that?
Yes,
Is
sir.
it in any way helpful to the prognosis?
Yes, sir. Post-operatively, we can explain the
No,
surgical
man, not post-operative, because once you have done it,
Yes.
it is the destiny of the patient.
Yes.
Pre-operative. This is what the entire study was.
Yes.
There is an infiltration there, and this is the prognosis. There is an infiltration less. This is the prognosis.
I think it's already clarified, sir. And what is clarification is that there is no direct correlation. He is not going to stop the operating also, isn't it? Whether it's infiltrated or not, you are going to operate when the surgery is indicated. I'm right?
Yes.
Thank you.
Thank you.
Next. You are going to call Murali Krishna, multi-purpose sleeved owl in innovative instrument for making entry point for all nailing procedure.
Good afternoon. I'm Dr. Murali Krishna, Associate Professor Orthopedics in Government General Hospital, Srikakulam. And today my topic is multi-purpose sleeved awl, an innovative instrument for making entry point for all nailing procedures. Coming to the introduction, this intramedial nailing is one of the most common procedures in orthopedic practice. And making an optimal entry point and passing the guide wire in the center of the medullary canal is very crucial for all these nailing procedures. The entry point should be precise and, if possible, amendable. During nailing procedures, most surgeons, especially the beginners, find difficulty in making an entry point and locating the entry point which is already made and passing the guide wire smoothly That is, sometimes the guide wire will miss the track and the entry point, and the guide wire will be going into the soft tissues. Or sometimes the guide wire, after entering the entry point, will be hitting one of the cortices, either anterior, posterior, medial, or lateral, but instead of going into the medullary canal directly. So the currently available armamentarium are, we have different types of awls in the market. That is, one is a cannulated awl or a non-cannulated, or a straight awl or a curved awl. All these have been modified over the years. And the problem with this conventional awls sometimes we face is, for the non-cannulated, we are having two types of awls, that is straight and curved. And we have difficulty in locating the entry point, which is already made. And the diameter of the awl, the tip, is 15 mm, so which is very wide. And once the entry point is made, and it is very difficult to change the entry point again. And coming to the cannulated awls, in obese patients, we find it difficult to locate the hole in the awl, and sometimes the bone gets stuck in the hole of the awl, making it very difficult or impossible to pass guide wire in the awl. So our aim is to make a single awl which is useful for all nailing procedures, for the femur, tibia, or the humerus, and an awl which is helpful in, which helps in easy passage of the guide wire. Coming to the literature, what the literature says is, for the systemic review, we have done a systemic review for an ideal bone awl, but could not find any useful information except for the product information. These are the certain newly designed awls in the market, which are specifically designed for the proximal femoral nail. So to overcome these, we have come up with a multi-purpose sleeved awl for making an easy entry point and for the smooth passage of the guide wire. Even a bent, slightly bent ball tip guide wire can be passed through this awl. So the specifications of this awl are, it has a curved outer sleeve. It has a curved outer sleeve and a sharp tipped curved trocar, and a T-handle for both trocar and the sleeve, for having a good grip of the awl and for manipulating the direction of the awl so that it stays in the center of the medullary canal, and also for easy withdrawal of the instrument after making an entry point. So the trocar specifications, it is slightly curved in the middle. The handle of the trocar is round and solid, and the diameter is 5 mm, and the length is 26 centimeters. And the sleeve specifications are, the handle is like a 1/3 tubular to accommodate the handle of the trocar, and the tip of the sleeve is beveled or tapered in order to push the sleeve also into the medullary canal. The length is 22 centimeters, and the outer diameter is 8 mm, and the inner diameter is 6 mm. So the instrument is designed in such a way that it can be used as a straight or a curved awl. The main difference between conventional awl and this awl is that the tip diameter and the curvature of the awl. The tip diameter for a conventional awl is very wide, that is 15 mm, and this multi-purpose is only 5 mm. And the curvature is at the tip in conventional and in the middle in the multi-purpose sleeved awl. Some of the changes that were made during the evolution of this design is, initially it was a straight awl and a curved awl, but finally it was only one straight, slightly curved awl which was prepared. And the diameter was reduced from 10 mm to 8 mm so that it can suit all bones. And the depth of the groove for the sleeve was reduced because the sleeve and the trocar used to get stuck while withdrawing the trocar from the sleeve. And length of the awl was increased from 20 to 26 centimeters. The study population, we have tested this awl in 25 patients at Government General Hospital, Srikakulam during the last 6 months. The same awl was used in intertrochanteric fractures, PFN, in 10 patients, and for interlocking nail or PFN in subtrochanteric fractures in 2 patients, and interlocking nailing in for fracture shaft femur in 5 patients, and interlocking nailing in fracture tibia in 6 patients, and in humeral shaft fractures in 2 patients. Taking the entry point, what is the procedure? The standard recommended entry point were used for all these bones. After confirming the entry point in both AP and lateral views in C-arm, we gently push the awl into the medullary cavity with gentle rotatory movements. So the trocar and the sleeve both should be pushed into the medullary canal, and the trajectory of the awl can be adjusted by just manipulating the T-handle for the central location in the medullary canal. After the sleeve enters the medullary canal, the trocar is removed and the guide wire is passed very easily, and the procedure of nailing is continued as usual. So this is a small video. So this is the awl. It is kept on the tibia. This is for the interlocking nailing of the tibia. The awl is positioned in the AP view, and also it is confirmed in lateral view, and with gentle rotatory movements, it's pushed into the medullary canal. And again, it is confirmed on the C-arm, and it is pushed again inside so that both the sleeve and the trocar are in the medullary canal, and again confirm it in the AP view. And after confirmation, the trocar is removed from the sleeve, and you can see the hole in the sleeve directly in front of you, and you can just simply pass the guide wire without any obstruction. And after passing the guide wire, with the help of the T-handle, you can remove the sleeve. That is the procedure of nailing. Then the reaming and all is continued as usual. So this is some of the cases. This is highly beneficial in intertrochanteric fractures, as it is very difficult to find the track of the entry point in comminuted bones. And this is intra-op picture showing the sleeve with the guide wire in situ. And this is one more case with the awl in situ, showing confirmation in both AP and the lateral views. And for the interlocking nailing of the femur, this can be used for the shaft fractures, the subtrochanteric fractures, and the distal third fractures with supracondylar nail also. And the main advantage is you can pass a bent ball tip guide wire with ease through the sleeve. Tibial nailing, as the direction of the awl is controlled, there is less chance of the guide wire hitting the posterior cortex. We feel this useful in suprapatellar approach, but we have no experience in it. So this is for the tibia, passes the guide wire, and confirming at the AP and the lateral views. In humerus nailing also, it is advantageous in humerus nailing also because of the smaller diameter. And results in conclusion, the time taken for the entry point was 2 minutes to 10 minutes, and the time taken for the passage of guide wire is few seconds or very minimal, and C-arm shoots for the entry point is 5 to 14, and there is no need of C-arm for passing the guide wire. There is thereby reducing the amount of radiation exposure to the surgeon. There is no iatrogenic combination while passing the awl. The time taken for the entry point and passage the guide wire was reduced about 3 to 10 minutes, especially in comminuted intertrochanteric fractures, thereby reducing the overall surgical time, reduced fluoroscopic time, and the amount of radiation exposed. The handling of the instrument is easy, and the surgeon completion. So advantages are: one single awl is used for all interlocking nailings. It is very useful instrument for smooth massage of the guide wire, reduces surgical time, and reduces work. And other uses for TENS, rush nailing, endless nailing, and square nailing, also it's used. These are my references. Thank you.
Thank you, Dr. Murali Krishna. Since you don't have time for a discussion, I'll call off on next paper, Dr. Aditya Shekhar Nyuka. Paradoxical worsening on imaging in the early treatment course of tuberculosis spondylodiscitis should be a concern.
Yeah.
Good afternoon. My topic is paradoxical worsening on imaging in early treatment course of tuberculous spondylodiscitis. Should it be a concern? This was a multiple center study. Spinal tuberculosis is a medical disease. The management depends on the response to chemotherapy. Traditionally, the response was monitored using serial radiographs and ESR. We have rich knowledge and literature regarding the radiographic changes happening during healing. Currently, MRI is the preferred modality because of its high sensitivity and enabling us in early diagnosis and monitoring the disease progression. However, the longitudinal changes on MRI imaging during healing are unknown. In our daily practice, we have three usual scenarios which we encounter while managing patients with spondylodiscitis undergoing ATT. In the first scenario, we have patients who are favorably responding clinically and have a favorable MRI response during follow-ups, and everybody goes home happy. In the second scenario, we have a patient with worsening clinical symptoms and worsening radiological features, and the treatment is obvious. Here comes the third tricky situation where there is a good clinical responding patient, but worsening on radiology, and multiple questions pop up in our brains. Are we dealing with a multi-drug resistant variant here? Or do we need to go for a surgery to prevent any complication at this stage? Or is it a paradoxical worsening which would happen in chemotherapy, which would heal uneventfully without any intervention at this stage? Because of the lacuna in the available literature, there are many issues which are left unanswered, like the normal longitudinal changes in the MRI till healing. What is the significance of worsening on MRI during chemotherapy? Is there a need for repeat MRI during chemotherapy? What are the significances of persistent changes in MRI after chemotherapy? The purpose of this study was to document normal longitudinal changes of healing during TB spondylodiscitis chemotherapy and correlate these changes with the clinical response of the patients. The study was conducted in 3 phases. In the first phase, we did a literature review using the Medline, Embase, and Web of Science search engines, looking for studies published between 1990 and 2020, using the keywords spinal tuberculosis, chemotherapy, MRI findings, and follow-up MRIs. And we were able to find out only 3 studies which had more than 1 follow-up MRI in their literature. Interestingly, all the 3 studies were published from India, and these were retrospective case series, and follow-up MRIs of different intervals were clubbed together in their reporting. In the second stage, we did an online survey regarding the practice preferences using the SurveyMonkey platform, where we recruited 30 orthopedic spine surgeons of various levels of expertise across India and posed them with the question, worsening radiology and good clinical response. Do you need a repeat MRI at this stage during follow-up, and are you concerned about this status? 68% of the spine surgeons of more than 45 years of age have opined that there is no need for any follow-up MRI at this stage, and 10% were concerned about worsening during on the MRI changes. And 52% of surgeons less than 45 years of age have opined that that they would obtain an MRI irrespective of the clinical symptoms, and 35% were concerned about the radiological worsening at this stage. In the third stage, we did a prospective multi-center clinical radiological study in biopsy-proven spondylodiscitis patients. And we obtained MRIs at the time of diagnosis and initiating ATT, along with serial MRIs obtained at 1st month, 3rd month, 6th month, 9th month, and 12th month after starting ATT. 52 patients were who were managed conservatively were studied in this study for correlation of radiological and clinical response. The study was conducted in these 5 institutes with Mallika Spine Center acting as a nodal center. These were our inclusion and exclusion criteria, where we have excluded immunocompromised individuals, patients with atypical tuberculosis and neurological deficits, which are symptoms for indications for surgery here. And these were the clinical parameters which were documented at the time of presentation and starting ATT. And these parameters were again looked after at every follow-up visit to monitor the clinical assessment. We have adopted an comprehensive clinical assessment tool called the MyMop2, which is a patient-centered tool having 2 questionnaires. The first questionnaire was filled at the time of diagnosis and starting ATT, which gathers information regarding the 2 main symptoms and activity level of the individual and general well-being of the individual prior to 1 month of presenting to us. And these are graded from 0 to 6, that is as good as possible to as bad as possible. The second questionnaire is filled at the time of follow-up and has an additional criteria called the symptom 3, the significance of which we can appreciate as we move forward. And any change that is decreased in the follow-up period greater than 1 in the mean MIMOP score can be considered as clinically significant. The radiological parameters observed in the study were changes in the hypointense signal in T1 weighted images, hyperintense signal in T2 weighted images in the affected bodies, changes in the size of the paravertebral abscess, and the number of affected vertebral bodies affected. These are the demographics of the study population. On clinical assessment, we found that the mean MIMOP score was decreasing steadily right from the start of the treatment till 12 months of follow-up. And this decrease was significant, which is more than 1 as discussed earlier. Similarly, ESR was found to be decreasing after the initiation of treatment during the study period, and it was reaching near baseline levels around 12 months of chemotherapy. And on radiological analysis, we found that in the initial period, there was an increase in the T1 hypointensity in the affected vertebral bodies, which was noted in 24 individuals, which resolved subsequently on continuation of ATT without any intervention. Similarly, in T2 signal intensities, there was an increased hyperintense signal in the affected vertebral bodies, which subsided subsequently in 20 individuals. And 15 patients had more number of affected vertebral bodies in the initial period. And there was an increase in the extent of abscess in 14 individuals in the first 3 periods. This slide shows the number of cases worsened at the end of the first month and third month during the analysis with respect to the radiological parameters observed in the study. However, none of these cases had any worsening at the end of 6 months. In total, 27 patients, that is 52% of our study population, had radiological worsening in the initial 3 months of chemotherapy. All patients showed serial improvements in mean MIMOP score and ESR irrespective of radiological findings. The difference in the clinical improvement among the individuals who have worsened on radiology and not worsened on radiology was statistically insignificant. Another strength of the study was adopting this MIMOP2, which has additional symptom 3, where 5 individuals have adopted additional symptom 3 as a result of adverse effect of ATT, but have healed uneventfully with minor dose adjustments. Coming to the initial question, is there a need for repeat MRI during the follow-up, especially at this stage where there is worsening? Paradoxical worsening on MRI in early phase is common, and MRI worsening after 6 months is abnormal. MRI is not indicated in the situation of clinical improvement. There is no necessity of extension of duration of ATT purely based on MRI features. And before the start of the study, the level of evidence available for the same question was here. And we expect to reach at this stage upon successful publication of this in a peer-reviewed journal. On concluding, for the first time, a prospective well-designed serial study was undertaken. This study bursts many myths, and this treating surgeon should be aware of these paradoxical findings during the early treatment course. Thank you.
Okay, good. Sir, I request judges to clarify the paper.
We started treating tuberculosis before MRI came in the field. That is about 35 years back. Did you find a relationship between MRI findings as well as the plain X-ray? There also we used to find in initial treatment, the radiological findings used to become worse because of increased vascularity and softening of the bone. Here also the same thing is working. Did you find a relationship with these two?
No, sir. It was the same thing. As my study has quoted, the previous evidence available is only expert evidence, but we want to publish it because as in the era of evidence-based medicine, we need a higher level of evidence-based criteria. So we have did a comprehensive study observing all the radiological parameters.
What judges is asking, what are the significance, how it is good for the patient while managing the tuberculosis of spine? How is the study is going to change the management? Because sir has treated a lot of patients in his experience without MRI and doing the MRI also. You want to do publish, that's why you want to do it. That's what you said, isn't it?
No, sir. Like in spite of worsening, we can be assuring the patient that because as you are clinically improving, the disease will eventually heal. There is no need to.
That's what
panic.
Sir is telling. Clinical correlation is more important in the practice of management of tuberculosis than your imaging technique. That's what they're emphasizing this.
Yes.
That's what you say.
You mean to say that
significant? That's sorry, sir.
no. You mean to say that you have to look at on the clinical symptomatology only, not the imaging.
So both were correlated. No?
Ah.
But at the end of the study, we want to tell the same thing, that clinical improvement of the patient is more important than radiology.
Yes, yes.
Yes, that is the emphasis. We
Then-
want to
no.
increase the level of the same thing which is prevalent in the.
Okay, well, do you think you have presented this paper anywhere else?
This we have presented, sir. earlier.
Where?
Yeah, in IOICON.
IOCON. Fine. You said there is no, this kind of study is not done, isn't it? First time.
No, there were 3 studies in India, but there were case reports where only MRI findings were
Case
reported.
reports.
Yeah, there were
But
case
for your
reports.
kind information, I will tell you this published by Indian author R. Singh, N.K. Magu,
Yes, sir.
and R. K. Rohila. It is published in Annals of Medical Sciences Research, Walters Newer Medical Publications. They have done 50 case studies. They have done clinico-radiological correlation in management of healing tuberculosis of the spine.
Yes, sir. I have
What's your
quoted all the.
comment about that?
I have quoted all the 3 studies in my
I know
slides,
that.
sir.
No, no,
Yes.
how it differs from their studies?
Yes, their studies, they have not obtained serial radiographs, sir. In their studies, MRIs were obtained at whenever the patient has presented to their OPD, and they have clubbed the MRI findings of all the patients together and with the clinical symptoms of all the patients. Individual analysis was not done in their study. And further, there was no reporting of adverse event in those studies. I have quoted all the 3 studies in the literature, available
Sir, any
literature.
more clarifications? So how it is beneficial to the patient from by your study?
So it is more beneficial to the treating surgeons because not to,
How?
because if it is published, it is going to increase the level of evidence.
No.
but
When you are treating practicality, how it is good for the patient? Whether it is
Patient
change-
will be well informed about the prognosis.
No, we are assessing clinical, radiological, whatever it may be. Clinical assessment, patient general condition improvement, your basic CRP, ESR, all those things you are taking into consideration. Simple X-ray also will tell you, isn't it? Because why I'm debating this, MRI is a costly affair, isn't it?
Yes, sir.
That is really essential to put all our patients when you are managing tuberculosis of spine. MRI is really required to follow every
Okay.
time.
It is not necessary. That is one of my conclusions, that
Thank
MRI
you,
is
it's
not
not
required.
necessary. Okay, we'll call upon next. Abdul D. Khan, therapeutic hip and ankle arthroscopy with bone marrow aspirate concentrate, early results.
Good afternoon, everyone. I'm Dr. Khan, the HOD of Orthopedics at Apollo Hospital, Vizag. I'm going to talk about my early results of therapeutic hip and ankle arthroscopy with BMAC, bone marrow aspirate concentrate. So I'm going to talk about BMAC, what's its constituents, preparation, bilateral hip arthroscopy for avian, which we did, ankle arthroscopy for osteocontrollation of the talus and osteoarthritis of the ankle. And I'm going to present my early results with minimum 6 months follow-up. Okay. BMAC basically is bone marrow aspirate concentrate, as I said. It's a good biological tool for the orthopedic surgeon. It has anabolic and anti-inflammatory effects, as we all know. It helps in the regeneration of various tissues, including bone, cartilage, nerve, muscle, which we are interested in. BMAC contains mesenchymal stem cells and growth factors. As you can see, mesenchymal stem cells have the ability to differentiate into any tissues which are of interest to an orthopedic surgeon. Okay, this is the manufacturer guidelines with Tricell, which we use in Apollo Vizag. You can see there are 160 million MNCs and 8 million CD34 cells in the concentrate, which we get around 8 ml. So I'm going to talk about the 11 gauge aspiration needle. I'm going to show that in the coming slides. Yeah? We take it from the anti-superior spine because I do bilateral hip arthroscopy and ankle in supine position. Okay, so I get around 50 ml of bone marrow aspirate, which we get in 2 standard tube X tubes, and then we use this CS03 clinical centrifuge, as you can see in the picture. So we don't use the fecal Haptic method, which was used before. We use density gradient Buffy-Coat method. The first cycle is 2200 RPM at 12 minutes and second cycle 2000 at 3 minutes. We get 8 ml of BMAC normally. If it's the bilateral hip arthroscopy, I use 4 ml in each hip. If it's in the ankle, I use 8 ml in the joint for osteoarthritis. But if it's an osteochondral lesion of the talus, I keep 4 ml in the defect along with Distilled fibrin glue and 4 ml into the joint. So just a recap before we go into bilateral hip arthroscopy, FECAT classification. We are mainly concerned whether it's pre-collapse or post-collapse because that's what determines what I'm going to do. If it's a pre-collapse up to 2, 3 and above is collapse, post-collapse. So bilateral hip arthroscopy for pre-collapse cases, I do arthroscopic assisted core decompression and I insert BMAC. Okay. The advantage of using arthroscopy is, in addition to the core decompression, I can deal with any associated pathology like a pincer lesion or any other synovitis, especially in post-collapse hips. And it also helps in the accurate grading of avian. Sometimes if it's late grade 2 or grade 3, we are not sure. There is a disagreement among the radiologists as well. In that case, if I go in and see arthritis, then I know it's grade 3. Okay, and also it's useful for guidance during reaming and curettage. Okay, sometimes we might penetrate the joint while cold decompression. That at that time, the whole purpose of cold decompression is lost. So it's a good guidance, yeah, using an arthroscope. So for post-collapse, I tend to do synovectomy, debridement, chondroplasty, microfracture, and insert the BMAC directly into the joint. So bilateral hip arthroscopy, which we did 11, and I did a 6 more, which are under 6 months follow-up, 17 till now. Supine position, traction table like DHS, lateral and modified anterior portals. I do right followed by left because I take BMAC from the right iliac spine. So smooth and FE 4 mm, 70 degree scope I use. Under CM guidance, I insert BMAC after tilting the table by a few degrees and leave it for a few minutes so that there is no leakage back in the core decompression tunnel. So our study, we got 11 patients with 6 months follow-up. 8 were COVID recovered who had taken steroids when they were ill, and 3 were non-COVID idiopathic. So out of the 11, 4 had pre-collapse hip on both sides. 6 of them had pre-collapse hip on one side and post-collapse hips on the other side. And 1 had post-collapse hip on both sides. This is the patient I'm closely following up because generally for post-collapse hips, we advise total hip replacements. And this patient is 8 months follow-up with significant reduction in symptoms. So 11 patients, 6 male, 5 female, and you can see the age is very less. The average is 30.5. They're all young patients. The follow-up is 6.9 months average, as you can see. So all cases were done as day case procedures. They were admitted in the morning and discharged in the evening. All were operated by me. They were mobilized 5 hours after the procedure with a walker frame under physio supervision and followed for 6 weeks, followed by gradual strengthening rehab. So scoring, we did numerical pain scoring, which is similar to VAS score, 0 to 10 grade. And we do it rest and activity as well. We also did WOMAC score, which we normally use for osteoarthritis. The range, as we all know, from 0 to 96. So this is the NPR score, which we used, similar to the VAS. WOMAC score, as we all are used to for osteoarthritis, 0 to 96, the range, as you can see, the full sheet. So this, I'm going to say a few films. I know the hip and ankle arthroscopy is not done routinely in the region. So post-collapse, you can see on the right, pre-collapse on the left, same patient, MRI, you can see, left side, the contour is maintained. This is pre-collapse, both hips, you can see the contour is maintained. The same patient, MRI scan. Post-collapse avian of the hips, this is the case I talked about, the one case which I did. This patient has a THR. She was very symptomatic when she came to me, but 8 months down the line, she has minimal symptoms. She's carrying on. So the goal here is to preserve the joint as long as we can, because they are all young patients. So this is the aspiration needle we use, which has multiple holes provided by the Tricell company, which we use in Apollo. So this is the image, II image during the hip arthroscopy. You can see the two, one for the scope, one for the stitching rod in the modified anterior portal. And you can see the guide wire, followed by the reaming, as you can see the II image for the accurate localization. This is the dry scope, of the pre-collapse that you can see on the right. This is the wet scope. You can see the pristine head below and the labrum above. Microfracture, you can see the cotyloid fossa. This is the case of post-collapse. You can see the OA changes on the cotyloid fossa there. Microfracture of the femoral head. You can see I took out all the unstable cartilage, and I'm using the half sleeve on the top to protect the soft tissues from the from the awl. This is just a picture of right hip arthroscopy I'm doing. You can see the 70-degree scope and the wand which I'm using in the anterior portal. This is the left hip arthroscopy I'm doing. At the same sitting, you can see the scope and the half sleeve in the anterior portal. You can see the cotyloid fossa, from one of the patients. You can see the femoral head on the right and cotyloid fossa on the left. Synovectomy I tend to do around the modified anterior portal. Usually the post-collapse hips tend to have a bit of synovitis because they're in pain. I do anterior capsular release as well around the modified anterior portal because it helps to give me the freedom for movement of the shaver and the wand which I use. So this is just a video of doing I'll come back to it in the end if I have time, how I monitor, what is the use of using arthroscope while doing a core decompression. I'll come back to it in the end if I have time. So osteocontrollation of the talus, this all we did ankle arthroscopy for, 3 of them. They're usually just a brief introduction about what they are. They're usually secondary trauma. There is repetitive trauma. They have recurrent ankle sprains. Why we get thin talus? Because the problem with talus is the articular cartilage is thin and the blood supply isn't great, as we all know. This is just one of the slices, the MR scan showing the OLT in the medial dome. Same patient as you can see here. This is a case of ankle osteoarthritis. You can see on the medial side, there is a kissing lesion there. She did not want any procedure. She wanted to preserve the joint as much as you can. So our study of 6 months follow-up, 3 with OLT, 2 with osteoarthritis, all had MRI scans and radiographs. They all were unresponsive conservative treatment for over 2 years. We did again, all were done as day cases, admitted in the morning, discharged in the evening. We did NPR score like the same with the hips, NPR scoring, rest and activity and WOMAC scoring done at pre-op and minimum of 6 months post-op. Okay, 3 male, 2 female, average again very young, as we know. The goal here is joint preservation. Average is 32.5 years and follow-up is 7.8 months, as you can see in the slide. Post-op rehab, I tend to keep them in a below knee slab for 2 weeks, mobilize non-weight bearing, after which I use a short pneumatic walker, partial weight bearing for 6 weeks, followed by gradual strengthening physio rehab. So ankle arthroscopy, I do in supine position, manual traction. We don't have the luxury of the traction kit here. It's very expensive. Tourniquet I use hanging over the edge of the table. Anteromedial, anterolateral portals. I use Smith & Nephew 2.7 30-degree scope. I can also use a posterolateral portal for outflow. I haven't used in these 5 cases. I had used it elsewhere. So in the ankle arthroscopy, I do synovectomy, debridement, chondroplasty, microfracture. Then I do a dry scope. If it's an osteoarthritis, I inject all the 8 ml I get into the joint. If it's an osteochondral lesion, I inject BMAC and fibrin tissin glue, 4 ml into the defect and 4 ml in the joint. This is just a picture. I'm doing ankle arthroscopy. Here my assistant is giving manual traction. Okay, across the time. So ankle arthroscopy, synovitis, synovectomy I do, osteochondral lesion, post-chondroplasty, dry scope, inject glue, microfracture, talar dome, distal tibia, excision of distal video impingement. So basically statistics we did more than 0.8. So it was statistically significant, as you can see, p-value less than 0.0. Ankle arthroscope 0.0. So it is statistically significant. This is the largest series of cases of post-COVID cases. So this is the first study looking into BMAC for post-collapse hips. So BMAC is definitely new kid in the block. We need more RCTs to see further evaluate the action. So we need more studies to further evaluate the real effects of
Thank you. Thank you, Dr. Abdul. Since we are running short of time for discussion, we'll move to next paper. Sai Krishna Gadde. Latitude of spontaneous primary spondylodiscitis in post-COVID-19 patients.
Good afternoon and welcome to OSSAPCON 2022. This is Dr. Sai Krishna Gadde, working at Mallika Spine Center, Guntur. And today I'm presenting my paper on spontaneous primary spondylodiscitis in post-COVID-19 patients. Novel COVID-19. This word is not new to anyone seated here. And this global pandemic is nothing but Third World War, against which the world is doing since late 2019 till date. It caused a lot of uncertainty, rise in mortality and crisis throughout the globe. And the disease ranged anywhere being from asymptomatic to acute respiratory distress syndrome and even death. And we have to identify that this is not a respiratory disease alone. And it causes a lot of after effects which are systemic. So we in the outpatient departments of orthopedics might have noticed an increase in the number of avascular necrosis of hips, reactive arthritis, septic abscesses, soft tissue abscesses, and increased frequency of spondylodiscitis. And this led to our interest to work on this section. And my aim of the study is to highlight, compare, and contrast the incidence, course, management, and prognosis of spontaneous primary spondylodiscitis among post-COVID-19 patients and non-COVID-19 patients, and find out if this increase in the incidence is secondary to COVID-19 and how the COVID-19 infections are different from others. So this study was conducted from April to November 2020, which was corresponding to pre-vaccination program period. And we took up 30 patients who were diagnosed with primary spondylodiscitis clinico-radiologically with 1-year follow-up. And we excluded the patients with previous history of lumbar surgery, recurrent spondylodiscitis, chronic steroid usage, and other immunocompromised states. So we fractionated the whole sample of 30 patients into 2 groups. First one is post-COVID-19, which contained 19 individuals. And we added patients having classical COVID pneumonitis requiring hospitalization and appreciable serum COVID-19 specific antibodies. And the second group is non-COVID-19, which had 11 individuals. All these patients had clinical radiological evaluation in the form of X-rays and MRIs, serum inflammatory marker evaluation, and appreciable COVID-19 specific antibodies. Further, the suspected tissue in all these patients was subjected to histopathological and microbiological analysis. Further, the disease course, clinical radiological features, management strategy, and prognosis in both the groups were compared and subjected to statistical analysis. So what did we find in the results? It is not a surprise to find a higher number of IgG values, IgG and IgM values in the post-COVID-19 group. But ESR and CRP values are also significantly higher in the post-COVID-19 group, in spite of the presence of infection in both the groups. And when we come to the MR imaging features, this is really a surprise for us. First of all, there is increased frequency of paradiscal involvement in the non-COVID group. And there is more average degree of vertebral body involvement in the post-COVID group, up to 83% of the vertebral body. And at least 2.4% is the mean number of involved vertebra in the post-COVID-19 group, and higher incidence of epidural abscess, intraosseous abscess, and psoas abscess in the post-COVID-19 group. And surprisingly, the disc-based destruction is lesser in post-COVID-19 group, and end plate erosion is lesser in post-COVID-19 group and higher in non-COVID group. And other features are the common region of involvement in post-COVID-19 group is lumbar, and in non-COVID-19 group is thoracic. And the commonest etiology in post-COVID-19 group is pyogenic. And in non-COVID-19 group, it is tubercular. And we did not find any fungal etiology in either of the groups. And more number of patients in the non-COVID-19 group responded well with conservative management, whereas post-COVID-19 group required surgical management. And 2 of these managed patients required revision surgery in the form of relapse of the infection and septic loosening of the implant. So what did we infer from these above findings? So the patients of post-COVID-19 group has shorter duration of presentation and progression of disease, higher vertebral body destruction, and more than 2 vertebrae are involved, and common region of involvement is lumbar. Disc-based destruction is usually mild and very rarely moderate. Paradiscal involvement and end plate erosion are less frequent, and more frequently we see epidural, intraosseous, and paraspinal abscess, and commonest etiology being pyogenic, which required higher frequency of surgical intervention. And when we come to the discussion, what COVID-19 has done is the pathophysiology lies in induction of vasculitis, microembolisms, bleeding dyscrasias, autoimmune reactions, and decreased antibacterial defense. Further, it caused significant lymphopenia in the peripheral circulation, especially low CD4 and CD8 counts. And further, it also caused hike in inflammatory mediators and pro-inflammatory cytokines. It also antagonized interferon responses, enhancing bacterial adherence, colonization, and invasions into healthy sites in the body elsewhere. In toto, COVID-19 has dysregulated the immune response and caused an immunocompromised state, which caused higher risk of secondary systemic infections. And another concept is COVID-induced vasculitis, which caused local ischemia and osteonecrosis, which further acted as a bed for infection. these all are complemented by the usage of high doses of intravenous and oral corticosteroids and empirical antibiotics during the active COVID-19 infection and hospitalization, which led to cross resistance to the infections in the later days. So why are we so much interested in post-COVID-19 patients? Because the presentation is very atypical. It did not clearly match with either the traditional pyogenic or the traditional tubercular style, in which though the duration, progression, everything is very rapid in COVID-19 patient, most of the patients demanded surgical treatment, and also relapse also was there. And higher incidence of epidural abscess, spinal cord compression, and intraspinal changes were seen. So the presentation of infection in COVID-19 did not follow any rule. And again, it's like discussion, we see a more incidence of pyogenic etiology with more vertebral body destruction and disc space preservation. Usually traditional pyogenic infection do not cause much of vertebral body destruction, and it does not spare the disc. Disc will be usually involved in traditional pyogenic spondylodiscitis. And another feature is posterior superior involvement is newer in this post-COVID-19 patients. And predominance of paravertebral abscesses are also formed in spite of being pyogenic. So these are the differences between regular pyogenic and post-COVID-19 pyogenic patients. And this is my case series where there is rapid progression of the disease within just like 3 weeks after the first presentation. And this one is an atypical posterior superior corner involvement in pyogenic etiology. And surprisingly, we also found the infection at level of spondylolisthesis in 2 cases of post-COVID-19 group. So it led to a doubt that is COVID-19 causing local osteonecrosis and instability at that particular segment, or is instability attracting infection? So that is one suspicion which aroused during this study. And these are the series of images in non-COVID-19 group which follow traditional paradiscal involvement, lesser extent of destruction, and epidural or intraosseous abscesses. So these are the few studies in literature. So far, not many studies are there having this much of study sample. This is a case report by Talamonti where he found out a spinal infection could have depended on the coexistence of an initially asymptomatic bacterial contamination. So what are the questions we got from this is, should we categorize this under a new category called COVID spondylodiscitis, which is not like traditional pyogenic and tubercular? Does it have a different pathophysiology? Or the rapid progression, is it because of a prior asymptomatic infection now causing a flare? Or it is due to the failure to control the virulence and aggressive multiplication? And what about fungal? And what are the conservative and surgical indications? What measures to take while screening? And the summary is, it's a first study with adequate sample, and screening in post-COVID-19 patients with high suspicion is needed. Importance to pyogenic etiology has to be given, and refrain from usage of empirical anti-tubercular therapy, like how we use in India. So be ready for new surprises in the future. Thank you.
Good work, Dr. Sai Krishna.
Thank you, sir.
Sir, any questions from the judges sitting down? From audience? No? Yeah, good new work and good message that we must keep the pyogenic infection in the mind before jumping into the tuberculosis. That's your one of the good message. Yes, sir.
See, of course, in a pre-existing condition like immunocompromised, diabetes mellitus, any infection cause immunodeficiency, immune system down, infection can flare up anything. Quite also one of the situation is a new situation to arise. Fine. Sure. After your study, what's your message to us? See, because when you have a back pain, you take MRI, you do the biopsy, you go for an serology. According to that, we are going to treat.
Sure.
Probably the flare-up of the cases may be high with a COVID infection. That's the only message. Apart from that, anything else?
So I just wanted to find out, like, apart from the higher incidence, like why the presentation features are not
See, in
following.
all these cases, pre-existing comorbidities I have mentioned, they have scored.
So we excluded all those immunocompromised conditions prior itself, sir. We totally got 46 patients having spondylolischitis, but we had finally only 30 sample because we excluded the criteria causing immunocompromise.
What I gathered information from your paper is,
Sure.
probably the COVID infections, the chance of spinal infection can be flared up, pre-existing or not, we don't know.
Sure.
But at the same time, I have questionable that whether it is causes the listhesis, number one,
Sure.
whether it is vice versa. How you justify your statement?
So that is the doubt which we had. So whether
No.
COVID is causing osteonecrosis and that regional instability due to pars lysis, or this instability has an attraction for infection seating.
Please.
Okay. Okay, sir. Thank you.
Thank you, sir.
No, does this have any relation to the amount of steroids which the patient has taken in that?
Amount of steroids which we could not get prior information, but people who had serious infection and longer duration of hospitalization, they had rapid progression with the formation of epidural abscesses and vertebral destruction.
Exactly.
Definitely, the severity of infection is correlating with the degree of discitis.
Right.
Thank you, Sri Krishna. We'll move on to the last paper of the session. The name is Mini Open, but not so many of the results by Bondili Sai Soumya.
Good afternoon, all. My topic for presentation is the name is Mini Open, but not so many on the results. Now I'm going to speak about rotator cuff tears and how we manage those tears. Coming to introduction, rotator cuff pathology is an important determinant of overall health status with a marked impact on individuals' quality of life. Treatment of the disease may include physical therapy, surgery, or a combination of both. The goal of all treatment modalities is to regain the pre-injury status of both the tissue and the patient. Most commonly used surgical techniques are traditional open repair, mini open repair, and arthroscopic repair. Development of this mini open repair took place because it had the potential advantage of smaller skin incision, less deltoid morbidity, cost affordable, and technically less demanding. The aim of the study is to determine the clinical and functional outcome of mini open repair of rotator cuff tear using UCLA and ASCS shoulder score index systems. This is a prospective study for a period of 24 months carried out in 50 patients who underwent mini open repair for rotator cuff injury and patients with symptomatic cuff tear, which was confirmed radiographically with MRI and who do not have elevation of symptoms. After 6 weeks of conservative management were included in the study. Patients who have associated fractures with rotator cuff tears are excluded from the study, and pain intensity was assessed by visual analog scale, and functional outcome was determined by activity of daily living, University of California, Los Angeles, American Shoulder and Elbow Surgeons Shoulder Score Index systems. Coming to surgical technique, we have used 3 to 4 centimeter skin incision, and deltoid was split longitudinally between anterior and middle raphe. Axillary nerve was protected at this point, and self-retaining retractor was placed, and cuff tissue was exposed. Now we have placed the traction sutures with the help of first pass device all along the tear, and we prepared the footprint on the greater tuberosity. Along with that, we performed the crimson duet technique, and then tendon was brought to the footprint and fixed with the preloaded suture anchors. Statistical analysis, the entire data is statistically analyzed using SPSS software 21 version for MS Windows, and in entire study, the p-value less than 0.05 was considered to be statistically significant. In this study, most of the patients were in the age group of 51 to 60 years, and 72% were males, and 66% were full thickness tears, and 34% were partial thickness tears. Age distribution of cases according to type of tear. In this study, we observed that age and type of tear are not relatable. Any type of tear could occur at any age, but full thickness tears are more commonly seen in males and partial thickness tears are more commonly seen in females. This is a case of 42-year female with right rotator cuff tear. Preoperatively, there is difficulty in doing range of motion, and postoperatively, she is able to do near normal range of motion. In this study, there is significant improvement in range of motion. With this, it is evident that there is improvement in the quality of life. And we have evaluated the pain using visual analog scale, which was improved from 7.44 to 0.44 postoperatively. And we evaluated the functional scores using shoulder-specific scoring systems like UCLA, ADL, and ASCS. In this study, we observed there is significant improvement of functional scores. The goal of rotator cuff surgery is to improve the patient's quality of life through the pain reduction and improvement in shoulder function. The type of repair performed depends on surgeon's experience and familiarity with the particular procedure. Here we perform mini open repair along with the crimson duet technique, which is a bone marrow stimulation technique. Crimson duet technique, we perform the multiple perforations on the greater tuberosity, which helps in better tendon to bone healing. Karimetol, they have studied efficacy of bone marrow stimulation technique in rotator cuff repair, which was published in Journal of Shoulder and Elbow Surgery in 2017. They stated that it enhances the histological healing and leads to higher mechanical strength. This is one of the simple technique, simple inexpensive technique which we can add to our standard procedure for better outcomes. When it comes to arthroscopic veins mini open, despite of many advances in arthroscopy, it is a technically demanding and costly, and it requires a huge practice for a surgeon to obtain proficiency. There are many meta-analysis studies which proved that there is no statistical significance between the outcomes of arthroscopic and mini open repair. So we can also use this mini open repair as a bridging procedure for rotator cuff repair during transition from or open to arthroscopy. When it comes to single row wins double row fixation in rotator cuff repair for fixation of tendon, we have options like single row or double row anchorage. These are the studies published in Journal of Clinical Orthopedics and Trauma and American Journal of Sports Medicine. They stated that healing rates was faster in double row, but the final outcome was same for the single and double row fixation at final follow-up. We generally prefer single row suture anchors for tears less than 3 centimeters and double row anchors for tears more than 3 centimeters. And all the anchors were placed at 45 degrees to the bony surface, which is a dead man's angle. This increases the pull-out strength of the suture anchor and also reduces the tension in the suture. Coming to complications, according to literature, rotator cuff repair have common complications like postoperative infection, stiffness, and re-tear. We have not encountered any re-tears or infection and stiffness throughout the study period, and mini open repair with all these advantages, it remains as a useful and affordable procedure for all the patients. Not only for patients, it helps as a bridging procedure for young orthopedic surgeons while learning arthroscopy. All these results concludes that the name is mini open, but the results are not so many. Thank you.
Thank you, Dr. Soumya. I think I'll request judges to clarify their doubts. Dr. Soumya, I have some few clarification. You said this procedure can be used as a bridging procedure. What it means?
Sir, what I mean is, while learning arthroscopy, we can use this mini open repair. As an young orthopedic surgeon, I want to learn arthroscopy, but we can use this mini open repair as a bridging procedure from open to arthroscopic procedure. While learning arthroscopy, it acts as a bridging procedure.
So you mean to say all
Yes,
arthroscopic surgeon learning, they have to open and learn, then to go for arthroscopy. That's the message you want to pass on to us?
No, sir. For an young orthopedic surgeon like me.
No. The message should be clear and clarified. What it means by bridging procedure?
Yes,
You
sir.
mean to say everyone should learn open, then go for an arthro?
No, sir.
See,
There
you
are-
know, I want to clarify why keyhole surgeries have invented after doing decades and decades together of open procedure. The millions of procedures have been done in arthroscopy
Yes.
worldwide since few decades. Why it is invented?
Uh,
One more
Yes,
thing, one more thing, you're thinking, you're telling it's a cost effective.
Yes.
And also you're using the anchors.
Yes.
Anchor is a cost effective, no?
Yes, sir.
And the
Anchor
same
is cost-
arthroscopy also, you can use the anchors with the
sir.
minimally invasive procedure.
Arthroscopy procedure itself is a costly procedure and
No.
anchor.
Why?
No, no, it's not a thing.
Anchors are the costly
It's
procedure.
not
why
the
it
way
is
you
costly?
should understand. What our clarification is that the invention of the keyhole surgery is that better access, better illumination, less morbidity, isn't it?
Yes,
That's
sir.
the invention of the beauty of the arthroscopy surgery. You are telling that you open and learn, then you go for arthroscopy.
sir.
Number one, you are not substituting your procedure to arthroscopy also. Number two. Number three, you are using the same anchor
Yes, sir.
suturings for your procedure
Yes, sir.
also. That differs that the costliest is nothing. You are equal to the arthroscopy. What is the message you would like to give to us?
Yes, sir. There are similar final outcomes, sir, in arthroscopy and mini open repair. So while learning arthroscopy,
Okay,
we can
thank you. Thank you very much, Dr.
use
Soumya.
this.
A
Anything
small
else?
question, sir. It's not question, actually. I think the paper is admirable because I also do the mini open technique only for the rotator cuff tear. And it has, in literature also, it has been proved that mini open is equal to arthroscopy. We might be cynical, but arthroscopy is definitely market driven in terms of rotator cuff. This is all everyone agrees, but a small modification of the procedure might have added to your results, because in arthroscopy we do that shaving of the undersurface of acromion, the decompression. I think that should have been added to your procedure, because that is the main component of the pain relief
Yes.
in any arthroscopic rotator cuff repair, because 50% of the cuffs, they don't unite to the greater tuberosity.
Yes.
Most of the patients come for us for pain relief, because that is what everyone seeks. And the abduction and everything, all the cases, even if I show my cases or you show your cases, abduction will be only 50% of the full range of motion. This is everyone knows. So I think addition of small that surgical decompression would have added much better to your thing. And the self-retaining retractors more than the normal mastoid
Excuse me. This session is not to explain your experience, not to
no,
add
sir.
on to this, your only clarification.
Yeah,
But at the same time, I appreciate your effort to ask questions. Number one, you admire this procedure because you are doing.
No, sir.
No,
That's
number
not the
one.
thing.
Number two, you told is a market-driven arthroscopic procedure. If you ask me, whole orthopedics is market-driven now.
Yeah, sure, sir.
You
Even I
understood
agree.
that? You
Yeah,
should not talk like that. You have to withdraw your statement. That's
Okay,
not the way.
I withdraw my statement, sir.
Please,
But
thank you.
definitely.
Thank you, Dr. Soumya.
Any questions? So if there are none, so thank you both the chairpersons, Dr. Jagdish Garu, Dr. Mallikarjun Swami Garu. So please move over to the center stage so that we would like to felicitate you. May I call upon Dr. Purnachandra Rao Garu onto the dais to felicitate our chairpersons. Hall B arthroscopy is about to start. If anyone is interested, kindly move towards that, Rest can be here in this hall. We will be continuing with the plasty sessions. And sir, Dr. Vijay Ragarao Garu, if you can move on to the stage, it will be very helpful to us too. Right. Thank you, sir. And before we go on to the next session, I would like to call upon Dr. Ramana Yashaswi Garu to, along with we invite Dr. Bhaskaranand Garu for this session. It's just a 1-minute session. We are going to launch a book which has been written by Dr. Ramana Maharshi Garu. Sir, since you are interested in the literature, he wanted you to open this. We are fortunate that we have been used on this dice is being used for the other things other than orthopedics too. Thank you, sir. Okay. All the people who have completed their lunch, kindly proceed to both the halls, either A or B. B hall is Scopy, A hall is Plasty. This message is to all the members who are in the dining hall.
Yeah, once again, we are on stage, another book. Dr. SSV Ramana, to my memories, if I go back, we worked together in the Bird Hospital for more than 3 years. And we have each our habit or fashion in writing small books. And this time he is coming out with some stories from a remote village. And we hope some more books will come out in future. Thank you, Ramana, for bringing it out. And you are asking our professor to come forward and release the book.
Thank you. Thank you all. Let's proceed with the next part of the session. I've already announced that there's no lunch break. It's a work lunch. So as and when you are free, please go ahead to the dining hall, have your lunch, and either settle down in Hall A or Hall B, because Hall A, any plastic people interested, please stay back. And anyone interested in Scopy, please proceed to Hall B. Now, so let me invite the chairpersons for this session. May I call upon Dr. Varaprasad Garu and Dr. Sita Ramanjanayal Garu onto the stage, please, to chair this session. The session is on knee and shoulder arthroplasty. I request the chairpersons to take over the further proceedings of this session.
Good afternoon, and it's a great privilege for me and Sita Ramanjanaylu to chair this session. First of all, I would like to invite this present scenario on arthroplasty. It's a wonderful topic. I would like to invite Dr. Arun Kumar, who will give a lecture on unicompartmental knee arthritis. Dr. Arun Kumar.
No. Good afternoon, everybody. I thank the OSSAPCON organizers for having me here in this wonderful conference. I'm sure it's a physical conference after a long time to get on with the topic. So this is not an uncommon picture that we find when we go in for a knee replacement. The lateral cartilage is perfectly healthy while the medial side is completely gone with bone-on-bone arthritis. Do we have to sacrifice this healthy, good-looking cartilage all the time? And that is the question that I would like to address. And I believe the answer is no. We have a choice where we can preserve this lateral healthy cartilage. So there are some very common myths about unicompartmental knee replacement, and I will focus on those myths and see whether they are true or not. The common myths are that UKR has no advantage over TKR, and it is applicable only for a very small population. And the most disadvantageous myth is that people like to do it for not so severe arthritis in young patients. And the last but not least, a lot of people give up UKR because they've heard or read that it has a higher revision rate than a total knee replacement. So first, let us look at whether UKR has any advantages at all over a total knee replacement. We'll compare function, complication rates, and ease of revision. So commonly in many studies, you would have seen that they would conclude that there is no difference in function between uni and a total when they use a knee society score. Knee society score is a score that was designed for total knee replacement patients, and it does not really accurately predict or measure function in high-end individuals who desire more function. So there was this new score that was used, which is called the forgotten joint score. It's we've all heard of forgotten hips, not so commonly forgotten knee joints. People sort of tend to remember that they've had a knee replacement. It gives them a niggle now and then. So this was quantified using the score, and you can see that TKR scores, which is the red bar, scores significantly lower than the blue bar, which is a unicompartmental knee replacement. More than 80 to 85% of people who get a uni almost forget their joints. Corresponding figures for a total knee would be in the range of 70%. The other thing that sort of really gives an immediate post-operative satisfaction is the early recovery. This is a lady who's had a unicompartmental knee, and this is a post-op day 2. You can see that she is comfortably walking well, and she's in the hospital. So less pain, early recovery, and quadriceps preservation definitely add to the speed of recovery. And even though we consider uni as half a knee replacement, more often it is 1/3 of a knee replacement, and it greatly preserves the patellofemoral function. We don't disturb it. We don't disturb the trochlea. So they get really good or speedy recovery with the uni knee. Then we've been all trying to get more flexion in our total knee replacements. There have been high flexion designs that have been trying to get more flexion, but high flexion knee is a gone phenomenon now. A lot of the high flexion designs had more failures, and we've sort of given up on high flexion total knee replacements. In contrast, uni is a truly high flexion knee replacement. This has been shown in a very good study in Asian patients, specifically in Korea. 71% of them were able to squat, 47% were able to kneel after a unicompartmental knee replacement. If you look at complication rates, it's not only revision. We'll look at some other interesting perspectives. This was a large meta-analysis of total knee versus unicompartmental knees. We all fear cardiac events, and it is 6 times lower with a unicompartmental replacement as compared to a total knee replacement. In a TKR, if you've done, I think 400 TKRs, you would have seen 1 cardiac event. That is the average. With the uni, it is 1 in about 1,800. Similarly, DVT and PE, very serious complications, 1/3 the risk with unicompartmental. Again, we hardly see deaths, but they do happen if you are doing large volumes. 1 in about 845 patients with TKR have a 30-day mortality. and it is about 4 times lower with the unicompartmental knee replacement. These are all based on a study published in Lancet. Again, we all dread infection after knee replacement. The risk of infection with the unicompartmental knee replacement is half. So infection risk is much lower with the uni knee than with the total. Other reasons like stiffness, manipulations, all these are much lower with the unicompartmental knee replacement. Again, when uni fails, there is the option of going to a primary knee replacement, but mind you, it doesn't happen all the time, but 2/3 of uni revisions can be converted safely with the primary knee replacement components. Comparatively, if a total knee fails, most of the time you are ending up using a stem or augments or a revision component. So I think we can, based on these things, I can tell you with confidence that UKR function is better, lower rate of several complications, and allows easier revision. So this part, most people reserve uni for young patients with knee osteoarthritis. TKR as well as UKR have very high revision rates in young people, especially over 55, younger than 55, and it is the same for uni. So uni is not a great option for very young people. Don't use it for people less than 55. In people over 75, on the contrary, uni has excellent results, shorter operative time, shorter hospital stay, and same survival at 5 years. Again, when the knee OA is not severe, the results are poorer with uni. So look for bone-on-bone arthritis as shown here. So the criteria for uni should be bone-on-bone medial arthritis, no cartilage loss in the lateral tibiofemoral compartment, no severe OA on the lateral part of the patellofemoral compartment. So this was a patient who had grade 4 bone-on-bone OA and he got a UKR. Lateral osteophytes, chondrocalcinosis, lateral subluxation that is correctable on the valgus tressue, these are all not contraindications for a uni. Again, the other mistake we commonly do is being very selective in choosing patients for uni. As the numbers increase, as you do more proportion, the uni complication rates will go down. So uni is ideal for older patients with severe medial OA. That is what I would like to tell you. Again, a lot of people think mobile bearing is the most or the best bearing for a uni. There are two designs. One is the mobile and the fixed. So I'll just go on. So this was a study that we published in COR in 2020. It was based on analysis of over 50,000 uni knees and TKRs. The 15-year revision rate was much lower with the fixed bearing insert as compared to a mobile bearing. And the last point, yeah, it is true that uni has a higher revision rate than TKR, almost twice the revision rate of a TKR. But if you look at a uni that is having pain, people easily go and revise it into a TKR. However, if a TKR is painful, they don't go and revise. So the criteria are different. People just, it is very easy to revise a uni, so people get a uni revision done very quickly. For the same Oxford knee score, a uni is 5 times more likely to get revised than a total knee. So revision is not the end point to compare uni and a total. Final message is, it is an excellent alternative to TKR in appropriate patients. Comparison between uni and total knee must look beyond revision rates. Young patients without bone-on-bone arthritis are not good candidates. It's the opposite. Ideal is an old patient with severe bone-on-bone arthritis. Fixed bearings in general perform better than mobile bearing unis. Thank you.
The questions will be asked today in the last 10 minutes. Next speaker, I would like to invite Dr. Shivaya. How I do 2KR in valgus knee. Dr. Shivaya.
Point. Start to do. Good afternoon, everyone. I am very thankful for Ungol Orthopedic Association and OSAP organizers for giving me this opportunity. Today, I am going to talk on correction of valgus deformity in total knee replacement. Coming to the pathophysiology, valgus deformity is different from the varus deformity. In varus, there is pathology on the tibial side. In valgus, there is pathology on the femoral side. Here, you can see here, in this valgus knee, we can see hypoplastic lateral femoral condyle and then lateral tibial condyle bone defect, soft tissue contractures on the lateral side, and soft tissue laxity on the medial side. When compared to the osteoarthritis and rheumatoid arthritis, in rheumatoid arthritis, valgus knee is associated with recurvating deformity. In osteoarthritis cases, it is associated with recurvating deformity. In rheumatoid, it is associated with fixed flexion deformity. When coming to the preoperative planning, it is very crucial. We have to rule out the referred pain and we have to rule out the septic focus. We have to keep all the ornamentarium standby, like CR, PS, metal wedges, augments, and screws. We may need constrained varus valgus implants. So I always examine the patient under anesthesia before going for the surgery. Under anesthesia, we have to examine that whether the joint is lax or stiff. If the joint is stiff, I go for liberal bone cuts and liberal soft tissue release. If the joint is lax, I go for conservative bone cuts and a conservative soft tissue release. I prefer medial parapatellar approach rather than lateral parapatellar approach. Once a joint is exposed, we have to do minimal medial release on the medial side because already medial side soft tissues are stretched out. So I prefer tibia first technique. Once the joint is dislocated, tibia is out. We can see the contained defect on the lateral side. So here the resection level matters. If the joint is in the recurvating deformity, we have to take less bone cuts. You can see here. Usually I take 6 mm bone cut or less from the contained bone defect, from the edge of the contained bone defect. And coming to the distal femoral resection, this is a very crucial step here. We have to take less femoral resection, 7 mm or less. Otherwise, joint may land up in recurvating deformity postoperatively that leads to instability and early failure. So in case of fixed flexion deformity, we can take more bone, like 9 mm distal femoral cut. But here, one thing we have to remember here is we should not chase the bone defect here. Coming to the balancing in flexion and extension, once I complete the tibial resection, I go for flexion gap balancing by just giving 5 degree sectional rotation. Why I don't give 3 degree sectional rotation here is lateral side already there is a hypoplastic lateral femoral condyle. So if you give 3 degree sectional rotation in this case, the femoral component may land up in 3 degrees in internal rotation because of the pathology. So that leads to maltracking patella. So that's why I give 5 degree sectional rotation. Once the flexion gap is balanced, then I finish the femoral cuts and go for extension gap balancing. This is the most difficult part of the surgery. The extension gap on the lateral side is the toughest part. So there are many techniques to balance the joint on the lateral side, like Dr. Insal's technique, Dr. Anavath technique, Dr. Whiteside technique, medial reconstruction technique, lateral femoral condyle osteotomy technique, the pie crusting, and I prefer inverted cruciform release technique by Richard Discard. So here the extension gap is balanced by this technique. In this technique, first expose the synovium on the lateral side here, and then protect the superolateral genicular vessels on the lateral side. Because this is the only vascularity retained after exposing the joint. If we cut these vessels, the patella may land up in avascular necrosis. In this case, once the vessels are protected here, here we can see the inverted cruciform. That means cross is reversed. We have to release the iliotibial band and retinaculum in an inverted fashion. So this is the horizontal part of the release, and then this is the vertical part of the release. So once iliotibial band and retinaculum is released, the joint will be balanced properly. So in this case, we have to protect the lateral collateral ligament. That is very important. So once extension gap is balanced, I do trial reduction. In this trial reduction, I do polo test. Because I am a CR surgeon, I prefer CR implant for correction of valgus deformity. Because once we retain the PCL, that is a very good medial constraint. Because already lateral medial side structures are stretched out. This gives excellent protection and excellent balancing. So in this case, pull out and lift out test. I follow this test. Pull out means if the PCL is lax, once we pull out the trial tray, it will come out easily. If the PCL is tight, here the tibial tray will lift off from the tibial surface. So in this case, nothing is there. So this is balanced very well in flexion. And then once the flexion gap is balanced, extension gap is also tested. Here, varus valgus is well balanced in this case. So once the flexion and extension gaps are balanced, I check for patella tracking. Patelloplasty is done, and then if we do inverted cruciform release, it gives automatically the patella track in position. That is the advantage with this technique. Once everything is done, we have to look for bone defects. Here, bone defects are managed with morcellized bone graft on the tibial side and a cement and screw technique. And then on the femoral side, this defect is managed with cement and screw technique. If the defect is big, we can go for metal wedges and augments also. So advantages with inverted cruciform release technique is it is very simple. We can correct even severe valgus deformities without releasing, without damaging any lateral collateral ligament, Popliteus, without doing any lateral femoral condyle osteotomy. It is easy to balance the gaps, and also we can use less constrained implants, which is very useful for Indian patients, which is cost effective as well, and faster rehabilitation is good thing. So when coming to the complications, in valgus knee, everybody is worried about the foot drop. Foot drop, usually it will be neuroproxia. I have encountered 2 cases of foot drop in my practice. So this can be managed very well if we recognize it very early. So what we need to do is we have to check the foot and ankle movements every hourly after surgery. If we notice any neuroproxia, we have to loosen the compression dressing, keep the joint in flexion, and we can use foot drop splint. And once we use, it usually recovers within 6 weeks to 3 months. This is a case 1, mild form of valgus deformity. Here, this is a valgus deformity which is corrected well. This is the pre-operative X-ray with a mild valgus deformity. This is corrected well. And then femoral side, the defect is managed with cement and screw technique. This is a case 2 of a 60 years male with bilateral valgus deformity. Deformity is corrected well. And this is the pre-operative X-ray, and these are the post-operative X-rays. I always use cruciate retaining implants. This is a case 3. This is 73 years female patient with a severe valgus, and also she has severe osteoporosis. Deformity is corrected well. Then this is a pre-operative X-ray with severe valgus deformity. Here, very rare complications I have encountered in this case. Because of the severe osteoporosis, once I dislocated the knee, medial collateral ligament got avulsed. This is a very unusual situation. Usually, MCL is very lax in this case. So I fixed the medial collateral ligament avulsion and immobilized the patient. Now the patient is doing very well. And I kept the patient on teriparatide injections. This case for the 65 years male with a moderate valgus deformity. The deformity is corrected very well. This is the pre-operative and post-operative video. Then this is case 5 with severe valgus deformity. Here we can see a lot of bone defects which were managed with cement and screw technique. This case 6 is a medically complicated and medically challenging case. 8 years female with a single kidney and coronary artery disease. We have done this one, very severe valgus deformity, which was managed very well. So this is the post-operative flexion which I got, and there is no foot drop as well. Even though I have corrected more than 40 degrees valgus deformity. This is the pre-operative X-ray, which shows MCL is very lax, which may need constrained implant. But This can be also managed with simple cruciate retaining implants, which are cost effective. This is what pre-operative, post-operative videos. Take home message is pre-operative planning is very crucial. We have to examine the patient under anesthesia. We have to do minimal bone cuts and minimal soft tissue release, flexion gap balancing by 5 degrees sectional rotation, and extension gap balancing by inverted cruciform release technique. And then we can do wonders. Thank you very much.
Thank you, Sivaya. I would like to invite third speaker, Unexpected Strikes in TKR, How to Solve It, by Dr. Jagdish Gar.
Small announcement, e-posters are being started in hallway. Please, those who have submitted for e-posters be in hallway.
Is it rather? Dintlo not problem. Okay, bye. No problem. Is it hello? Put the slideshow. In March, Malano, Elipotan, already in a place. Back end. First slide. Oh, let's go. Respected Chairman, good afternoon all. I think all are in sleepy mood. So I request the Chairman to extend 1 more minute extra for me because time is lacking. Anyhow, this presentation is what are the problems actually I faced in the theater, all the cases. So I listed anyhow, this list we'll see instead of wasting time reading that. The most common problem is medial collateral ligament, where either it can from femoral side, mid substance, or on the tibial side. Anywhere it get injured while we are doing knee replacement. This is the mid substance tear, which is very common due to your saw, oscillating saw. If you can't protect, you won't put your lever there, your saw will go and cut it. So one should be very careful. Once it got gone, it is very difficult to repair mid-substance tears. So my way of managing this one is, I will harvest the semi-T graft, and that is the semitendinosis, which you are seeing under my scissors. And you must be prepared in the theater. If you are a regular knee or hip replacement surgeon, you must have this graft harvesting from the ACL set. Otherwise, you have to run. There's the thing always you must keep to harvest that graft. Once you've done the harvesting, you see the length of the graft and the graft being prepared. You can see that the lengthwise, I can double breast that one, that graft, and that you can see that two. I won't have pointer. Okay, it's all right. Anyhow, you can see the ethibond sutures 2 places. And then second important instrument you must have from the ACL set is beath pin. So that is the beath pin going into the 2 beath pins going from the condyles to the opposite side, from medial to lateral, and same both the wires, one end, one end you can take, and you can pass both the wires on the opposite side. That is on the lateral side, we passed the 2 wires, and then you can suture that one with a button, or directly you can suture that one, and other half, that is important, other half is there, bring it back. So it is double breasted. You have very good medial support. MCL is totally reconstructed. And that is once after reconstruction, you apply the valgus stress. You can check the ligament status and all. Then the second problem, commonly sometimes, just now my good friend, regular TKR surgeon, also showed you the avulsion of the medial epicondyle from the medial distal femur avulsions. So those can be same thing. Once again, you can use the ethibond pull out sutures there, and you can pass the bead pins and take to the opposite side. Don't tie that one. Don't hurry in that. Implant first. After your implantation, you can use the buttons, which endo buttons you can use there. It is shown, and you can tie on that, giving the appropriate tension for the entire MCL. So that is, you can see the picture there, the medial collateral ligament being tightened there. That's used. The other problem, it can avulse from the femur tibia, from the femoral side, and also the associated non-union fractured patella. So once I reconstructed the patella, then I noticed that there is a problem with my avulsion of the medial epicondyle with the MCL. So here, just now we saw the good work. You can put 2 3.5 screws. So you must also keep one set of 3.5 mm with the different lengths to reconstruct. And that's 2 screws, and that is the post-op X-ray where the medial epicondyle with MCL being repaired. So other one is, it can also avulse from tibial side, and there is the avulsed one, medial side, just like Bunnell's type of pull out and pass it to the medial to lateral in the tibia to the anterolateral compartment, and then once done the implantation, we can suture back that one. So the tibial avulsions can be treated well. So if it is a less constrained implants, if you've done the repair properly, the less constrained implants can be used with the direct repairs. And post-operative management, if you've done the proper repair, you need not immobilize the patient. As routine, you can treat the patient, mobilization, weight bearing, everything. Only you can give one ACL brace to give the valgus, to reduce the valgus and varus forces on the ligament. And no doubt, this is the important point. You must avoid the iatrogenic injuries to the MCL. I told you, using the proper sleeves, retractors, and using the saw blade with care will help you. Another one I encountered is the popliteus tendon injury. So I thought, okay, popliteus tendon injury, nothing. Anyhow, we are using the constrained, semi-constrained knees. We need not bother. But if you go to the literature where the popliteus tendon and the lateral collateral ligament laxity, which is common in the varus knees, will cause of late 23% instability. So please don't neglect the popliteus tendon. It takes a couple of minutes to repair it. You can just suture with a Vicryl one and leave it. It will heal nicely. That is the suturing back. Then this is another one. We'll put the lever on the lateral side. The patellar tendon get avulsed. Okay, this can be repaired with the ethibond and all. This is the one I finished my surgery, and I am asking for the just the closure or washout final, and my assistant staff is not giving me the zoom or whatever it is. Sir, please look there, look there. I'm looking, what's there? I'm not seeing. And finally, he showed me that one there. Oh God, how it came there. So be careful about the impactors. You see this impactor, the one is not there, it is lying in the joint. So just look into your impactors before closing it. This is another case, interesting case. I done the knee replacement, the PS. I thought it's good. Everything is fine post-operatively, fine. The patient came after some time like this, right? They say, I went back and saw what happened. There might be a small fracture there that caused this problem. So be careful. Just look for it before closure. Anyhow, I done the conservative revision. I retained the tibial side. I changed it on the femoral side with the stem, added the stem, and patient done well with a good flexion. This is another one, bad knee, and I done that. While doing that, the medial condyle fractured. So I put a screw and I used the highly constrained construct there. By looking at this X-ray, you must be prepared. You are not only keep your regular implants, you must keep the next constrained stage for option on the table. You can't run. If you not have this TC3, it will be in the problem. So be careful while dealing such cases. The last case is a obese patient. We done surgery and fine. After 4 hours, my assistant came, sir, I'm not feeling the dorsalis pedis. So alarming. Immediately pushed to the radiology, done the angio. You can clearly see the block there. So luckily, we done the balloon immediately and cleared the block and the circulation re-established. And this is one should be very careful while you are putting the central lever. It will go and pick the popliteal artery and causes the compression and intimal layer injury, local thrombus, blocks it. So take home message, careful placement of retractors, meticulous care in soft tissue handling and bony resections, identify the complication as soon as possible and treat it. Thank you very much.
Thank you, sir, for explaining wonderful complications that shows your abundance of experience regarding joint replacements. I would like to invite management of FFD in TKR by Dr. P. Chandrasekhar.
Respected teachers and my dear colleagues, greetings from NIMS Hyderabad. Coming to my topic, fixed flexion deformity in total knee replacement. Fixed flexion is the common knee deformity in the patients undergoing total knee replacement. Isolated flexion deformity is rare. Most of the times it is associated with either varus or valgus. The flexion deformity basically increases the energy expenditure in the gait cycle. So it is not biomechanically friendly. And management starts from the preoperative period with the physiotherapy and intraoperatively complete the correction of the deformity and postoperatively protecting the knee and the supervised physiotherapy. And then residual flexion contracture has low function scores. Coming to the definition, when a knee is unable to extend to 0 degrees, either actively or passively, that is a flexion deformity. And literature says 60% of the patients undergoing total knee replacement do have a flexion deformity. Coming to the pathology, knee arthritis with severe pain and recurrent effusions, and then intra-articular adhesions, and then total capsular contracture gives rise to a flexion deformity. And then the problems may be in the soft tissue or in the bone. The soft tissue, the tight posterior structures, and a lax anterior or weak extensors. And coming to the bony, the loss of a posterior femoral condyle or tibial condyle, and thin soft patella and patellofemoral arthritis, and leading to poor mobility, and it is compounded by osteoporosis, posterior osteophytes, and loose bodies. But in inflammatory diseases, the common causes are bony ankylosis and the soft tissue contracture. And preoperatively, you have to evaluate for the coronal plane deformities, grade the flexion deformity, and check for the preoperative range of movements, and the radiographs to rule out the posterior condylar deficiency. And then Lombardi has classified flexion deformities into mild, moderate, and severe, less than 10 degrees, 10 to 30 degrees, and more than 30 degrees. The surgical steps include posterior osteophyte removal, posterior tibial osteophyte removal, and then posterior capsular release. And these are according to the severity of the deformity. The additional distal femoral cut, gastrocnemius release, collateral ligament release, popliteus release in rare cases, and then upsizing the femur to reduce the flexion gap. Coming to the grade 1 contracture, the principles of correction are very simple. It is an ordinary straight midline incision with a standard tibial and distal femoral cut, and correct the coronal plane deformities. Now, as per the insole, you have to get a rectangular flexion gap. And then this is with the resection of the posterior condyle, release of the posterior capsule, removal of the osteophytes and loose bodies if there are any. And then once you get the rectangular flexion gap, balance the flexion and extension gaps. And this is the picture showing the removal of the posterior osteophytes. Basically, you have to go back to the posterior condyle and release it and remove the capsule from there, and then remove the osteophytes. That increases the flexion gap. And this is the flexion and extension gaps. And this is the deformity, what we start. And this is the correction at the end of the surgery. On the table, it should be in extension. Coming to the moderate contractures, apart from the releases what you have done previously, the PCL has to be removed. It is the posterior capsule is superiosteally elevated from the posterior condyle and then released proximally. If there is a still flexion extension mismatch, do additional distal femoral cut. So whenever there is a extension gap is less than the flexion gap, when the extension gap is narrow, you do additional distal femoral cut, then it allows the flexion gap equals to the extension gap. And then coming to the severe contractures, the collateral ligaments, if there are involved, they are also can be released to certain extent, and the capsule to be separated from the collateral ligaments, and a transection of the capsule has to be done from the tibial side. And then in a very severe contracture, whatever is that is tight, that can be removed. But in such cases, the collateral ligaments are also get injured. In such cases, it is always better to use a hinge prosthesis. Coming to the grade 1, you can use either a CS or CR, whereas in grade 2, you have to use a CS. As the deformity increases, one has to sacrifice the PCL. So that's why better always have either a CS or hinge prosthesis nearby. Postoperatively, to start rehabilitation as early as possible, keep pillow under the ankle, not under the knee. Knee immobilizer until the quadriceps becomes strong, and manipulation under anesthesia is not at all a choice. Complications, incomplete correction, and then recurrence of the deformity, flexion extension instability, peroneal nerve injury. And coming to the cases, a male aged about 20 years of hemophilia arthritis, bilateral flexion deformities of the knees, which was, you can see the deformities, and which was operated left side first. And this is at the end of 1 year. Even right side was operated, and it is the end of 2 years. You can see when we go for more distal femoral cut, the joint line rises up and the patella becomes patella paja, and the patellofemoral articulation problems do occur. So that is the problem with the amount of distal femoral cut. And this is another female aged about 63 years with a flexion deformity. And then this is the to start with, and this is at the end of the surgery. And this is the post-operative radiograph. This is another case, a 50-year-old female with a flexion deformity of the knees. And these are the deformities. And we did a PCL sacrificing a knee in this case. And this is the post-operative X-ray. Coming to the summary, in a mild case, you can go for a CS or CR and the standard bone cuts, remove the posterior osteophytes, balance the PCL in CR. And then moderate deformity, the posterior capsular release, only PS knees are to be done. And severe deformities, when is more than 30, only PS knees with additional distal femoral cut, and then additional distal femoral cut, posterior capsular release, and release of the collaterals. And very severe deformities, always keep ready the hinge prosthesis. And even in spite of doing all this, sometimes on table, the knee gets very straight, and post-operatively, knee goes into little flexion. That's because most of the times, once the anesthesia is over, the contracted posterior structures will get little more into the flexion, whereas the quadriceps, which is weak, until it gets stronger, it is difficult to keep the knee straight. Then one should not be worried, because even in the literature, it is said that a gradual improvement in the knee extension can be expected up to 3 years after the surgery in the knees with the fixed flexion deformity. So in conclusion, complete correction of the flexion deformity is essential in a TCAR with OA knees, whereas some degree of deformity stretches in RA. So in RA, you can leave 5 degrees of deformity, whereas in OA, you should not leave any deformity. The soft tissue release is the key. Proximal tibial resection, one should avoid going below 1 centimeter of the proximal tibial cut, and limit the distal femoral cut until to the collateral insertion, and then keep constraint knees implants ready, and post-op rehabilitation plays a big role. Thank you.
Thank you, sir. Thank you. Next, I would like to robotics in knee arthroplasty by Adarsh Parity.
A very good afternoon to everyone. I would like to thank OSSAPCON for inviting me today. Glad to see everyone in the hall in person. Yeah. So I've been invited today to speak on an upcoming topic, which is robotics in knee arthroplasty. So first we need to ask ourselves, we had such wonderful talks about total knee replacement, such great results, but why robotics? When we have good outcomes already with TKR, excellent results in experienced hands, as you can see, many different implants getting to all types of needs. You have CPS, CR, you have high flexion, and navigation is also there. So why do we need robotics? That's what I want to answer in today's talk. So when we say the word robotics, usually we think of these guys, the good guys, the bad robots, but this is what usually pops into our mind. But this is not what our arthroplasty robot looks like. The most common robot I think people knew before arthroplasty was the Da Vinci robot for general surgery. So I'll be speaking about the Stryker Mako 4th generation robot. That's the one that we use. So first question many people ask is, does the robot do everything? The answer is no, it only assists us. So if you can see the burr or the saw is attached to the robotic arm. I hope you can see my cursor. Oh, it's not. Okay. So you can see there that we are still doing the procedure ourselves. We're still doing the procedure ourselves, but it is only assisting us. Now you can see that there's a haptic there. It allows us to make sure that we're not cutting any extra bone outside the boundaries which are set for us. So not all robots are the same. There is this classification by Chen et al. There is the boundary control robots, which are like the example is a Smith and Nephew Navio robot. The semi-autonomous, which is what we are using, the Stryker robot, where there's a human interaction and constraint within the boundary and which is fixed to a robot. Okay. And then of course there's the autonomous robot like the Merrill's robot, which the surgeon is not even putting his hand on the patient. He's just standing aside with a remote and the robot is doing its thing. Just a brief clips of these. This is the Merrill robot. This is the Navio on the top left. Sorry. Yeah. Okay, so if you can see over here, this is the Navio. It's something like a burr where you can just burr out within the boundaries. And this one is the Merrill robot where you can see the surgeon standing on the side and the robot does its own thing. It sculpts away at the bone. So this is a completely automated one. So we are talking about the Mako robot. This is what we are using, the semi-autonomous. So we are still doing the surgery ourselves, but it's attached to the robotic arm. So if you can see here, most of the time you can look at the screen because the boundaries are already defined. So you will make sure that it does not allow you to go outside of those boundaries. So this is what the Mako robot looks like. This is a semi-autonomous one. So to embrace the robotic technology, we have to start thinking outside the box. All these years we've been doing mechanical alignment, where you want to take your cuts exactly perpendicular to the mechanical axis. Now we are accepting something known as a functional alignment, where you can see the picture on the right side. Is there a pointer? Yeah. If you can see over here, you can take a 3 degrees in varus or valgus, depending on how you want your joint to be. So you can actually balance your joint just by rotating your cuts and moving your implants around. So if you see over here, the mechanical alignment is the first one and the functional alignment at the end. The femoral component distal cut is always target 0 for us in mechanical. But now in functional, we're allowing 0 to 5 degrees of varus or valgus, depending on what kind of joint you have. And even if you see the tibial cut, in mechanical, its target is 0, but in functional alignment, you can go plus or minus 3 degrees, depending on what kind of joint you have. But the most important point is you cannot do functional alignment without the help of a robot. So all these years, why we go for mechanical alignment is because we cannot exactly say 2 degrees, 3 degrees. It's not possible. But now with the robot, we can do that. So the Mako robot can do all three, but I'll be speaking about total and partial knee at the moment. Total hip I have in the hip session. So the point is, what is the need? So the advantage is we like to say A, B, and C. First thing is accurate sizing, perfect balancing, and 100% precise cuts. Okay, so we have enhanced planning, dynamic joint balancing, and the robotic arm assisted preparation of the bone. So the first thing is the 3D planning. We get a CT scan of every patient, and that patient's 3D model is reconstructed before the case. So every single patient, we have the 3D model in front of us so that we know exactly what we're dealing with. Next thing is the dynamic joint balancing. While the case is going on, we can make sure that we know exactly what are the gaps on valgus and varus stress. And of course, the haptic boundaries, it does not allow us to go outside these boundaries. So you're protecting the extra bone from not getting cut and the ligaments as well. What about partial knee replacement? As you all know, it's a technically demanding surgery like Dr. Kannan mentioned, and you need to be very, very precise over here. And the robotics help to prevent overstuffing of the medial compartment, and you can get exactly the right amount of stuffing that you need. This is the way the bone is prepared in a partial knee replacement. We burr out the extra bone within the haptic boundaries. So in brief, the workflow of the Mako is you have the pre-op planning, the OT setup, the array placement is similar to navigation. We have to give in the patient landmarks and bone registration. Then you do your intraoperative adjustments. Finally, you do your bone preparation within the haptic boundaries, trial reduction, and your final bone preparation. The OT layout, the robot is on the same side as the patient, as the surgeon, sorry, the ipsilateral side. The bone registration, what we're doing is a process of which the CT-based model is mapped onto the patient's bone. Already CT scan is taken. We are confirming to the robot that in real life, the patient's bone is matching the CT scan so that we can go ahead without any problem. Of course, you have to capture the landmarks and do the registration. Initial days, it takes a bit of getting used to, but with time, it becomes very fast. Hardly takes 1 to 2 minutes. Dynamic joint balancing, we aim for 18 gaps, both in extension and flexion. That is the size of our implants together. So how we do that? We're doing a little bit of tinkering around. So if you can see here, all our gaps are, we want to bring all these into 18, extension, flexion, lateral, and medial. We anchor the tibia, we start giving it a bit of varus, then you start getting your gaps starting to close down. You can move your tibia up and down. You can move your femur into valgus. Now see, I'm going to anchor in the femur and put it into varus. And you can see how it's changing over here. So the whole aim is to bring all these 4 boxes down to 18 just by doing some modification on the implant. So this is what functional alignment is. At the end of the day, we're going to aim for 18, 18, 18, 18, and that's get a perfectly balanced joint inflection and extension. Okay, then at the end, we have the haptic guided bone preparation, as I mentioned. Distal cuts, chamfer cuts, and everything are done with this. And this is what the chamfer cut looks like. As I said, within the boundaries, you make sure that you're not cutting any ligaments. Once the boundary turns green, that means you're locked. You cannot move outside that boundary, and you're quite safe to go ahead with the cuts. Now you may ask, what's the difference between this and navigation? So we have some advantages over navigation. First of all, we have a 3D image based. So you have the accuracy of the bone registration. You have pre-planning, which gives you accurate sizing. Shape matching of the femur till now we were not able to do. We can recreate the posterior condyle offset now. And of course, it even helps us with the haptic boundaries. So I'm not going to go into too much of detail, but if you see the bone registration in the robotic, it's quite easy because you already have a CT scan. But in the navigation, you have to paint the whole femur and it doesn't give you as much accuracy as you would get in a robotics. Joint balancing again, here, as I showed you before, you can just do a little bit of modification in the cuts itself, but in the navigation, you still have to put in your jigs and still do it on your own. Of course, the final important part is the haptic, which are going to allow you to prepare the bone without any problem. So if you think about it, navigation is just like a planning tool or a map, but robotic is GPS. It tells you where to go in every single turn. It doesn't leave you halfway there. What a procedure time, we were initially taking longer, then we became time neutral, and now we're actually doing it faster, hardly 45 to 60 minutes with the robot. So what does it mean for the patient? End of the day, it has to matter to the patient. We are seeing reduced surgical time and blood loss, unparalleled accuracy, smaller incisions and reduced tissue trauma, less pain due to reduced tissue trauma, and of course, faster recovery. So next question, if yes, then why Mako? Why this particular robot? We like this because it is a CT-based one, gives us more accuracy. It's the only robot which uses the haptic boundaries. It has all the 3 applications, including hip. It's only system, as I mentioned, haptic boundary. It's got a lot of literature over the last 15 years, and it has less pain in the 90-day post-op period, 92% satisfaction at 2 years. These are all literature I've taken out. Less pain, less time to discharge, and less opioid need. And if you see in partial knee replacement, Mako versus manual, the Mako has higher accuracy in all the implant positions. Okay. And as I said, the literature, it's basically what I'm talking about is only about the Mako. At the end, what are the outcomes looking like? That's what matters at the end of the day. We have a very fast recovery. This lady was the first Mako partial knee that we did. This is the day 2, and she's sitting nicely on her on the floor and talking to us. This gentleman, one week post surgery, he went back to his walking in the garden. Not that we can't do it without the robot, mind you. Just saying that we have fast recovery with less amount of pain most of our patients. This patient, day of surgery, is able to lift up his leg, straight leg raising as possible. And we can do in gross deformities as well. You can see this lady, we managed to get nice straight knees. Valgus knees also we can do with this. We managed to get, this is a severely valgus knee. And it was going into hyperextension as well. You can see, and we managed to get a nice straight joint for him as well. Why are we getting these better results? We feel that there's maintaining the internal homeostasis of the knee by titrating our bone cuts. So we're reducing the amount of soft tissue release that we need to do by just changing our cuts a little bit by 3 degrees varus or valgus. The haptic control is giving us less soft tissue injury, and we have less time with the knee subluxate. We don't need to subluxate the tibia until the tibial preparation. So tibial cut is also done without subluxating. We have one study coming up where we are studying one side manual, one side robotic on the same patients. We've already collected 100 patients, and now we are getting our results very soon. Thank you so much.
Thank you, Doctor. Now I would like to invite the next speaker, Dr. Vinod Kumar, to give a lecture on periprostic joint infection in TKR.
Excuse me.
Respected Chairman, seniors and my dear colleagues, good afternoon, everybody. Today I'm here to present about periprosthetic joint infections in TKRs. Surgical site infection is the most dreadful complication following total knee replacement. It's a nightmare for the surgeons and also for the patient. Though its incidence is 1 to 2%, but with growing number of TKRs, more and more cases are being reported. The diagnosis can be easy if the patient presented with a pus discharge from a joint, but the dilemma occurs when there is swelling, warmth, and redness around the wound. In such cases, go for lab, and if there is joint effusion, go for synovial fluid analysis and check for any cell count and neutrophil, increase in neutrophil percentage. Then get the radiographs and check loosening in all the zones of the imaging X-rays. Check for prosthetic progressive loosening and periosteal bone, new bone formation by comparing with the previous films. Remember that X-rays are not specific or sensitive, but scintigraphy can be more accurate, but its cost and availability is less. So here is the Musculoskeletal Infection Society criteria. They say that a joint is infected if any one of the major criteria is present. If in the absence of this major criteria, if any of the 4 of the 6 minor criteria, if it is present, then we can say that joint is infected. And how do we classify it? There are many classifications out there, but around the world, majority of the people or research workers says that these infections occur within 1 year of surgery, are initiated at the time of introduction of microorganisms, at the time of surgery, due to the introduction of microorganisms at the time of surgery. So what are the factors that increases these infections? That include patient factors, operation theater factors, and surgeon's factors. If you consider all these and try to prevent these infections, then we can prevent these joint infections. So here are the guidelines to prevent these infections. So one should identify and treat the infections remote to the surgical site before operation, get adequate control of blood glucose, ask the patient stop tobacco consumption at least 30 days before surgery, and limit the preoperative stay as short as possible, and ask the patient to take a shower bath with antiseptic agent the night before the surgery, and give antimicrobial prophylaxis, particularly third generation cephalosporin, within 1 hour before surgery. And if required, hair removal should be done, that too immediately before surgery with the electrical clippers. And the appropriate use of antiseptic agent for skin preparation, particularly chlorhexidine, can help us in preventing these. And always use laminar airflow theaters with restriction of the operating room personnel. So what causes these infections? Research says most commonly Staphylococcus aureus is the culprit, but there are various other organisms that can cause. Usually the pathogen source is endogenous, that too from the skin, but exogenous source can also be, should never be mined. And these are the variables that should be considered before planning for surgery. And there are many management options like antimicrobial suppression therapy, to the implant retention procedures, and rejection of prosthesis when doing revision surgeries, or arthrodesis or amputation. Antimicrobial suppression therapy can be chosen in case of superficial wound necrosis and stitch abscess. If in case there is stable prosthesis or under low virulent organisms, and it can also be used in case of patient is not fit for surgery. Though its success rate is 16 to 25%, you can try that in these wound necrosis and stitch abscess. If you're going to the surgery, the goals of surgery should be to eradicate infection, and we should elevate the pain and improve the function. Here are the surgical options that can be chosen for doing the surgeries. Implant retention procedures can be done in early post-operative infections or acute hematogenous infections. Division surgery should be considered in late chronic infections, and salvage procedures should be chosen if these procedures are ruled out, particularly in case of deep resistant infection, loss of extensor mechanism, and poor soft tissue covers. So as I said, implant retention procedure should be chosen in a well-fixed process without any sinus tracts or abscess in the joint. And there should be good local soft tissues in the joint on you open it. And it's better to avoid in case of chronic infections of more than 4 weeks, and also in people with infection with soft tissue defects that will make skin closure impossible. There are various papers favoring for these open debridement and poly exchange. So if though its success rate is less, if there is any doubt, so better to open the joint and clean it and change the poly if possible. Recently, there are many papers suggesting favoring for one-stage revisions because some people may be doesn't accept two-stage revisions. But this one-stage revision should be selected in particular in few people only with low patients with low BMI, and they should have doesn't have any comorbidities. There is no abscess or sinus tract, and the organism should be of low virulent and susceptible. Here in our hospital, we have done 2 cases for short-term with good short-term success rate. And two-stage revision is gold standard procedure because it gives us 70 to 85% success rate. In that we do in first stage implant removal, debridement and cement spacer is kept, and in second stage we do revision TKR. Why two-stage means the bacteria may be protected from the antimicrobials because they form biofilms around the implants and become persisters. To remove these persisters, one should remove the implant and all the infected material and the hardware so as we can decrease the burden of the biofilm such that post-operative antimicrobial therapy can eradicate the remaining infection. So if, on the day of surgery, if there is sinus tract, inject some methylene blue into it and explore it and excise the previous scar. And remove all the tissues that is stained by the methylene blue and also the implant and cement particles. And thorough debridement should be done, and we should freshen the bone edges and give a low pulsatile wash. And the space should be maintained by the cement spacer, which will prevent the soft tissue contraction. It also maintains the sufficient grade of joint stability, and also the cement spacers provide intra-arthur concentration of the antibiotics. Cement spacers are of many types, static and articulating, but there may, and articulating also there are many types are there. It may confuse us, but there is a good paper which shows that there is no clear difference between existence of between 2 types of spacers. But however, articulating spacers appear to be have superior functional outcome and give good result in case of easier reimplantation and allowing the degree of range of motion between these 2 stages. And which antibiotic should be used? This may be a major problem for us to choose it. Usually broad spectrum antibiotics can be considered like cephalosporin, clindamycin and rifampicin for biofilms and vancomycin for MRSA. And in spacer, we can use either vancomycin or tobramycin or aminoglycosides. 4 grams of vancomycin should be given for 40 grams of cement. And duration of this IV antibiotic should be given till the lab parameters are normal, usually 4 to 6 weeks, and then we can plan for second stage revision. On the day of revision surgery, we should keep all the implants, constrained implants with just stems, sleeves, and polyspacers, and also keep hinged TKR and standby so that if we may need it, we can use it. And here are a few cases where we have done 2-stage revision TKR successfully with good outcome after 5 years too. This is case 2. Where we have done hinged knee because the medial condyle was gone. So we have kept the hinged TKR. So if, what is the option if again the revision also is getting infected? In such cases, one should go for knee arthrodesis, which is surgical fusion of joint and making it immobile and stiff. Usually the optimal position for it is 10 degrees of axonal rotation and slight valgus and 10 to 20 degrees of flexion. Here are the 2 cases where we have done successfully this arthrodesis. And this is another case. In case of rheumatoid arthritis and MRSA, the patient is not willing for second surgery, so we have done directly the knee arthrodesis. And how do you grade these success of treatment? We can grade that there is no recurrence of infection for after the surgery, and there is microbiological and clinical eradication of infection without relapse. And we can say that they have got a successful treatment. And the classification of success will be short-term, mid-term, and long-term. So to conclude it, The pathogens that cause SSA are usually endogenous. The gram-positive cocci are the most common pathogens. Prevention is more easy and important than management. The perioperative antimicrobial prophylaxis, medical surgical techniques, and infection control practices. And implant procedures are helpful in early onset infection. Two-stage revision is ideal in eradicating the late onset infection. And arthrodesis of joint should be considered as salvage option. Thank you, one and all, and OSSAPCON for giving me this opportunity.
Thank you. Next topic is management of bone loss in revision TKR by Dr. N. Jagadish.
Good afternoon to all. Thanks to the organizing committee giving me this opportunity. Thank you. I'm going to talk on bone loss management in a revision TKA. What we face the challenges whenever we are doing the revision knee. The one thing is the fixation issues and the ligament instability and bone loss. We are going to see how we manage the bone loss. For any surgery, preoperative planning is the key to success of the surgery. You spend more time on preoperative planning rather than spending time in OT. Whenever you're planning to do revision TKA, keep all the options available like implants, intermedullary stems, wedges, augments, screws, cone sleeves, especially when you are practicing in periphery. That's if it is available, keep the bone graft available, and backup you keep the hinged knee. So radiological evaluation of the bone loss. So when compared to the CT, it is less informative. When you do CT, you get the more information in bone loss. Widely used the classification is AORI. Anderson Orthopedic Research Institute has given this classification. It is more useful in planning and management of the bone loss. So type 1, it has a good metaphyseal and cancellous bone at the original joint line. In type 2A, 2B, you will have the loss of cancellous bone, metaphyseal bone at the original joint line. And type 3, you have the loss of one condyle or two condyles. So we'll see how we manage the type 1. Type 1, as I earlier said, that it is the loss of metaphyseal and cancellous bone at the joint level. If it is less than 5 mm, you can manage with the cement alone or cement with the screws and intramedullary stems. If any revision using the intramedullary stems gives the advantage that it gives the axial and rotational stability of the implant. You can offload the implant host bone intersurface also by using the intramedullary stems. So some of the case examples I'm going to show you how I managed the bone loss in revision scenario. So type 1, you can see this pre-op X-ray. You will not see much bone loss. Okay. See, bone loss you will see after removing the implants only, after debriding everything, cement, all the debris, you will come to know the original bone loss. This is not like the good cancellous and metaphyseal bone. You can see this can be managed with only intramedullary stems. So you can see the immediate post-op X-ray and the 8 years follow-up of the post-op X-ray. You can see that. So not only managing the bone loss in revision, you should focus on the biomechanics of the joint. Like you should maintain the joint line as well as the posterior condylar offset. You should not migrate, keep the femoral component proximally or distally. See, this is one more case example in type 1. See, you can see this like distal loss of the femur. So managed with bone graft with screws to maintain the joint line. See, this has been fixed with filled with cement. You can see that lateral angle. You can see that it has been because to maintain the joint line, to keep the femoral component in original joint line. See another case example, like type 1. It's not much bone loss, managed with intramedullary stems and screws with cement. And some of the bone graft, impaction bone graft also used in this case. So one more case example, type 1. See, whenever you're doing like a stage 1 procedure, while removing the components also, don't damage like more bone, like try to take out the components without the bone loss. See, you can see this. This I have learned from Dr. Gurwadi sir. This he used to call it as a staked osteotomy. Keep the broad osteotomy, and over that you keep the thin osteotomy. By keeping this, you will not damage the tibial bone. See, the same. It's managed with screws. Means it's if the patient is affordable, what I prefer to use augments and all. If the patient is not is economical, means not affordable, you can manage with the screws and cement. So 9 years follow-up of the X-ray by using only intramedullary stems and cement and screws. So some of the studies says that Lotke used cement alone in 59 knees. Means that the defect is 10 to 20 mm, follow-up is 7.1 years. 43 knees are non-progressive radiolucent lines and one failed, needed revision. And long-term results says that good, you can use the cement alone if the defect is 10 to 20 mm. DOR study says that they have used 54 patients with type 1, 7 years follow-up. Only one had loosening and progressive radiolucent line. Ritter used 57 patients. The defect is 9 mm. After 3 years follow-up of 25% had non-progressive radiolucency lines and the bone cement interface, but none of the components has failed. After 7 years, there was no progression of radiolucency. Type 2 defects, like here you can manage with modular metal augments. It's easy to use, available in different sizes and shapes, and you can allow the patient immediate weight bearing. Only thing is it's cost effective. See the failed, one of the case example, failed uni knee. Whenever you're revising uni knee, you will see most of the times the bone loss is much in the tibial side, not in the femoral side. This has been managed with augment. Femur side is like primary components. See, metal augments results are very good. Like Patel, JV et al. They published in 2004 102 cemented revision TK they have done in type 2 defects treated with augments, uncemented stems, 7 years follow-up. Survival rate is 11 years in 92%, 14% non-progressive radiolucent lines, no significant complications. Even Lee et al. Study also says that it's a very good option to use in AORI type 2 defects. See, one of the metaphyseal sleeves and porous tantalum cones is available. It can be used in type 2 defects and type 3 defects. The sleeves gives the fixation as well as it fills the defect. The cones only it fills the defect. The porous tantalum metaphyseal cones useful in 2B and 3 defects. Advantages, you can use it as quick. It's available in numerous sizes and shapes. You can allow the patient immediate weight bearing, no resorption. Only disadvantage in this is it's very difficult to remove. Where I have used one of the cases this metaphyseal cones. It's a very good. So results of porous metal cones in tibia. This study says that they have used 15 revision TK with a tibial cone in type 2B and 3. 12 cemented stems, they used 3 uncemented stems. Mean follow-up is 34 months. They say that the good osteo integration and there's no failures. Same cones can be used in femoral side also. The study says also that it all demonstrated means osteo-integration is good. There's no failure. So one of the case example in type 3, the AORI type 3 defect, where I have used metaphyseal sleeve. This is, you can see that it's a lot of metaphyseal and cancellous bone loss at the joint line. Only the condyles are left. In this case, it's better to use metaphyseal sleeve. This gives the well fixation. You can maintain the joint line also easy with the metaphyseal sleeve. So one more case example in type 3. See here, it's a very huge bone loss. You can see that in trial, there's a huge bone loss at the tibial side, the metaphyseal region. Here, there's no, means option is limited. I have only one cemented metaphyseal sleeve that I put it and filled with cement. Here I used to prevent the early loosening, I used thin 2 mm K-wires inside. That's not visible in this cement. So you can see a lot of cement here to build up that defect. So Amar Ranawat says that he has used in 33 revision TKA and 2.3 years of mean follow-up, 84% complete osteo-integration and 16% partial osteo-integration stable. He says that 0% unstable and subsidence. Segmental replacements is one of the option in AORI 3. It's but use it with caution. It's a way one of the segmental replacements case where I've used is in periprostic fracture. Is the patient is 80 years old. It's very osteoporotic, and I prepared to go with segmental replacement. And you can use structural allografts also. The disadvantage with this late graft failure and resorption is there. You can use with cautious. It's one of the case where I used structural allograft. Earlier I said that it remain an option in difficult cases, structural allografts. The key thoughts are AORI type 1, type 2A, you can manage with cement alone or cement with screws and with intermedullary stems. And type 2B and 3 metaphyseal sleeves are cones for larger defects. Massive segmental femoral bone loss, use segmental replacements or structural allografts. In massive tibial bone loss, use structural allografts, especially in extensor mechanism disruption. Thank you for your attention.
Thank you. And I would like to invite the last speaker of this session, Dr. B. Chandrasekhar, to speak on shoulder arthroplasty, current concept. Dr. Chandrasekhar. After this, we will have 10 minutes for discussion. And by that, we close this arthroplasty session.
So, good evening, everybody. I want to thank OSSAPCON organizing committee for giving me this opportunity to give a lecture on this prestigious venue. And I think it's a surprise that shoulder replacement being spoken about on this dais along at par with hip and knee. I think maybe at the end of my lecture, you will accept that in the coming few years, shoulder is going to be given a proper place, shoulder arthroplasty too, and not just shoulder surgery. So I'm Dr. Chandrasekhar. I'm a director of shoulder surgery at Sunshine Hospital, Hyderabad. So it will be surprised to know that the first joint replacement was done on shoulder, not on hip and knee. And that was in 1893, by Jules Semney-Pin in Paris. That's for a tuberculosis shoulder, actually. And it worked well for 2 years, and then they have to remove it because the infection has reoccurred. Now, whenever I say, or anybody says about shoulder arthroplasty, most of the commonest image that comes to our mind is the Neer's monoblock process in the late 50s and the 1950s and 60s. And originally it was devised to deal with complex prognosis fractures. And then in the 1980s, it has been converted to be used in a total anatomic shoulder. But shoulder arthroplasty has progressed a long way from this Neer's process, which was there in the 1950s. Now you have these various things that is available in your armamentarium. You have a stemless process. This is not a resurfacing. This is a stemless one. There is slight difference between resurfacing and stemless. Here in stemless, you cut the head and then put a stemless one. In resurfacing, you preserve the head and put a cap over that. So, and you have a short stem, and you have a regular stem, and you have a regular fracture stem, and you have a total shoulder with the polyglenoid. You have a total shoulder with the metal back glenoid, and you have a reverse shoulder, and you have a reverse shoulder with a short stem. So where are we lacking? I think we are at par with your hip guys and shoulder and knee guys. Now, the commonest surgery that is being performed is hemiarthroplasty. And hemiarthroplasty, the commonest indication is fracture. And of course, sometimes we do come across AVN, especially given the current pandemic with steroid abuse. We are seeing a lot of AVN hips. I think others must agree with me. He must be seeing a lot of bilateral hip AVNs, and we are seeing shoulder AVNs also. Of course, even there earlier, but with the pandemic, it's increasing. And arthritis, of course, we prefer to do a total shoulder, but in younger individuals who are less than 40, 45 years, we try to do a hemi because we are worried about the loosening of the glenoid polyethylene component. And whenever you want to do a total shoulder and the glenoid bone stock is inadequate, probably you have to be happy with the femoral head. You cannot implant a glenoid in that. So, few things about fracture hemi. Fracture hemi has a special stem. It's not the regular hemiarthroplasty, regular total shoulder. Here, the bulk of the proximal metaphysis is less, and the fins, where you can reattach the tuberosity to the fins. And if you see carefully, the proximal metaphyseal region is uncemented, and the lower part is cemented. The diaphyseal part is cemented. So the metaphyseal part gives for the tuberosity fixation, and it allows space for the tuberosity to heal. And the one problem with fracture hemi is that because of the fracture, we have lost the anatomical landmarks, and it is difficult to determine the height and version. Of course, there are certain guidelines, tips you have to follow to determine the proper height of the process and proper version of the process, which will decide your success. And the most important thing in fracture hemi, I think there are a lot of people have experience with NIRS process, earlier NIRS process. There are a lot of failures. It's not just because the process is not so good. It's also because people didn't care much about the tuberosity reconstruction. So somebody, if your hemi has to work well, along with your proper implant, proper height, proper version, the tuberosities have to be reconstructed well, and the tuberosities have to heal. A well-healed tuberosity will give full elevation and full rotation. In fact, it's much better than doing a reverse shoulder process. But the problem is how well you do it. So if you see here, this is a fracture hemi. So you remove the head and then put your stem there. That's anybody can do. But if you observe carefully, there are a lot of sutures going around. These are strong non-absorbed sutures through the tuberosities, not through the tuberosities actually, through the rotator cuff. And we use these sutures to refix the tuberosities back onto the stem and onto the shaft. If you see carefully the post-operative picture, the tuberosities are well reconstructed and well placed. And once this heals well, you will get a very good result. And if the tuberosity is going to non-union, your process is a failure. So this is how you reconstruct it. And stemless hemi, yeah, whenever it's a bone preserving technique, whenever you can preserve bone, you preserve it. So any case where you can do a stemmed process, you can get away with doing a stemless process. So it is an alternative to stem process. But especially if you see the CT scan there, it's a old post-traumatic arthritic case where the proximal humerus is malunited. And you will agree with me that doing a hemi, putting a stem into this is very, very difficult and very challenging and fraught with complications. If you see, this is my case. You see the second X-ray there. You see here. So this is how we have done the stemless process. No problem at all. So no problem. I don't even bother about the metaphysis and diaphysis. And the patient is doing very well. And coming to anatomical total shoulder, indications are primary osteoarthritis. And remember, primary osteoarthritis exists in shoulder. It is not, you don't think it doesn't exist in shoulder. There is primary osteoarthritis. Of course, the incidence is very less. Like our team, Dr. Guruvarid and others do 100 TKRs every day, every week. Probably we do one a week or once in 2 weeks. But it exists. And inflammatory arthritis, rheumatoid arthritis especially, can affect your shoulder. Ankylosing spondylitis can affect your shoulder. And whenever required, you have to go for a replacement. Contraindications, if there is associated rotator cuff tear, the regular femoral head can become unstable. So don't use a total shoulder or a hemi shoulder when the patient has a rotator cuff tear. And again, if you don't have a glenoid bone stock, you obviously cannot implant the glenoid there. Stems, as I told you, we have short term, you have standard length stem, you have cemented stem, you have uncemented stem, you have fracture stem, and nowadays what we call convertible stems, wherein I do a hemi or I do a total shoulder. When I want to convert this particular process into a reverse shoulder, I need not necessarily remove the stem. I can keep the same stem and just change the components and convert into a reverse shoulder. What we call the convertible stem or a platform stem. Glenoid mostly is a cemented glenoid. Use a keel glenoid or a peg glenoid, and peg glenoid has slightly better advantage compared to keel. The central peg is
approach depending upon the surgeon's training and surgeon's experience. Some people, they prefer direct anterior, transgluteal or Harding approach, or anterolateral. My choice of preference is posterior. Once exposing the hip joint, capsulotomy after capsulotomy, neck osteotomy is the key factor that we need to take care of. The amount of the neck that we need to retain to get the vertical offset right. So usually we prefer 1 to 2 centimeters cut from the lesser trochanter. After osteotomy of the neck, we go to the acetabulum exposure. In case of acetabular retractors placement, either it is the right or left, 12 o'clock, 6 o'clock position retractors are similar. In case of right, we need to go for 2 o'clock position in anterior retractor and 8 o'clock position coming to the posterior retractor. We need to take care of the sciatic nerve here. And in case of left hip, the 12 and 6 o'clock positions are common. But the anterior retractors comes to 11 o'clock position and the posterior part retractor comes to 4 o'clock position. If we were able to plan properly, preoperatively, peroperatively also, few factors we need to consider thoroughly. Transacetabular ligament. This is the key factor which can help us peroperatively. If we are unable to plan preoperatively with the X-ray and all, peroperative also by checking the proper status of the transverse acetabular ligament, we can place the cup properly. The version part in particular, TAL can guide us peroperatively to keep the cup in place. Coming to the reaming of the acetabulum, we need to check the depth of the acetabulum that we need to ream with. The teardrop will give us an indication how much we can medialize the cup, how much we need to ream the medially. If the thickness of the cup is enough, we have to start the reaming with the smaller size cup to medialize, in order to medialize the cup. From there onwards to the size of the acetabulum. Coming to the reamer size, if we check the head measurement, if the head is approximately 46, we may go up to 5 mm plus for the reamer. After that, we can check the acetabular cup size with the 2 mm plus size of the reamer. Sorry. Coming to the femoral preparation, we need to check the femoral canal diameter on the plain radiograph, and peroperatively we need to make the entry point more towards the lateral part of the femoral canal while broaching to avoid the varus placement of the femoral stem. When we were able to see the 360 degrees view of the acetabulum with proper placement of the retractors and the TAL visualization, we will be able to place the cup in proper inclination and version. Usually 40 degrees is the approximate inclination we need to look for and we should aim for. And coming to the version part, it is around 16 degrees. Femur broaching, we need to see the proper appropriate size, better to undersize the femur component. After thorough placement of the trial components, we need to reduce the joint and check the stability part of the total processes peroperatively by means of shunt test, limb length measurement, by measuring the patellar and at the level, patellar level and ankle level. With the clinical assessment peroperatively, we can come to a conclusion whether there is any limb length discrepancy is there or not. After confirming all these things only, we need to go for proper implant, true implant placement. Take home message is stick to the basics regarding the position, exposure. All those things seems to be very simple for us, but while execution, if we don't follow the basics properly, it lead to lot of headaches. Stick to the basics, plan properly, execute accordingly, check thoroughly, close confidently, and sleep peacefully. Thank you. Thanks for the OSSAPCON for giving me these opportunities, and thanks for my mentors.
Thank you very much, Sivaram Krishna. And now I request Dr. Ijazuddin to deliver his talk on which stem to choose and why in primary THR.
Good afternoon, all of you. At the outset, I'd like to thank OSSAPCON Organizing Committee and my mentors, Dr. Uday Krishna, for giving me this opportunity to present my topic over here. I would like to speak about which stem to choose and why in primary total hip arthroplasty. I'm Dr. Mohammad Ijazuddin, practicing as a consultant orthopedic surgeon at KIMS Hospital, Secunderabad. Total hip arthroplasty is a very successful procedure which provides great relief and gives good mobility for a patient. It is a successful surgical procedure available today. With its continued success, total hip arthroplasty is increasingly being offered to younger patients. So the majority of patients now having total hip arthroplasty, the age group is coming down. Earlier, it might be in the elderly age group, but even patients as young as 20 as 30, as you have seen in COVID, more patients have been turning up with avascular necrosis. So these total hip arthroplasties have been increasing. So there have certain issues also in the long run, so which we need to find out, and we need to plan the surgery accordingly. The important predictors of total hip arthroplasty outcome is appropriate patient selection, implant selection, surgical technique, and most importantly, positioning of the components. As we previously told by my colleagues, pre-operative planning is most important in this surgery. If you're not planning properly, you're planning to fail. So pre-operative templating is performed in clinical practice to determine the size of femoral step that is likely to have the best fit. Intraoperative refinements are made to select an appropriate stem. Undersizing of the stem leads to lack of osseointegration. This can lead to later subsidence of the stem, and also it can lead to fractures and other issues. Oversizing a femoral stem can lead to iatrogenic periprosthetic fracture in the operating room itself. So it is always, I'll say, prudent when doing a total hip arthroplasty to do multiple trials, and we should be very careful the way we handle the proximal femur. It is better to use a C-arm to see the stem size if we have any doubt. The patient-specific variables are age, sex, and body mass index. But all these are basically pointers to the most important thing which determines the femoral component selection, that is the bone stock. Now, as you all know, a proper full-length hip X-ray showing the full femur is needed to make a decision whether to go with either a cemented or an uncemented stem. In a full-length X-ray, I will say both an AP and a lateral view is required to see how the medullary canal and the cortices are. In this, the most important points which we need to see are the lesser trochanter and a point 10 centimeters lesser distal to the lesser trochanter in the femur, and we should see the endosteal width of the femur and also the cortical width. As had been told previously by Dorr et al. In the Dorr's classification. In this, a ratio is calculated in the canal diameter 10 centimeters distal to the mid portion of lesser trochanter divided by inner canal diameter at mid portion of lesser trochanter. As you can see in this diagram, we should basically divide CC, the lines joining CC, which is at the lesser trochanter, by the lines joining the points B and B. So this gives us the Dorr's ratio. Now, according to different types of canals, according to the level of osteoporosis or bone stock, the three classification subtypes are A, B, and C, which are less than 0.05, 0.5 to 0.75, and more than 0.75. In type A, which is in mostly young males having good bone stock, you have cortices which are seen on both anteroposterior and lateral X-rays. These type of people generally tend to do well with an uncemented type of proximal femur prosthesis. Type B is having some amount of bone loss in which there is thinning of the posterior cortex, which can easily be seen on the lateral X-ray. And these type of patients, not all, but mostly can do well with a well-selected implant that is uncemented. Now, type C, that this is the most difficult of the three because the cortices are very thin and there's poor bone stock and they are amenable for intraoperative fracture due to very fragile bone. So these type of patients intraoperatively also need to be handled very carefully, and no sudden movements should be done while trying to manipulate or reduce the head. Typically, there is thinning of cortices on both views. So these ideally were to be cemented type of proximal femur prosthesis, but nowadays the indications are changing. This is a basic classification, but the selection should be for uncemented or cemented prosthesis should be done on a case basis. This is a diagram again showing the bone stock. As you all know, there are three types. The first one, on which is closer to me, will be the champagne glass type of appearance. And then there is the middle variety, which is the type B. And lastly, the stuff pipe type of appearance of the proximal femur, which can be seen on these X-rays. Ideally, you should take both AP, anteroposterior and lateral view of both. So here you can make out there is progressive loss of bone as we go from A towards the C. Now, this is very important when you are planning the surgery. So all pre-operative patients of a total hip arthroplasty, this type of X-ray should be taken and your planning should be done. This is of utmost importance. Now, coming to stems, there are two basic stems which are used normally in the primary total hip arthroplasty, which is the cemented and the uncemented. Cemented femur stem, basically we use polymethyl methacrylate, commonly called bone cement, to function as a grout, producing an interlocking fit between cancellous bone and the prosthesis. Cemented stems fall into two broad categories: taper slip and composite beam. Taper slip work on the force closed mechanism, whereas composite beam work on the shape closed mechanism. Uncemented femur stem, total hip arthroplasty, relies on a biological fixation of bone to a surface coating on the prosthesis. Initial fixation is achieved by inserting a prosthesis slightly larger than the prepared bone bed, generating compression hoop stresses and obtaining a so-called press fit. Uncemented femur stems exhibit a large range of designs employing wedged, tapered, cylindrical, modular, and anatomic shapes. They have lot of additions like fins and ribs for added stability. Splines, flutes, and slots are used to reduce modulus of elasticity. Uncemented prostheses encourage bony interlock either by bone on growth or bone in growth. These are a couple of post-operative radiographs depicting total hip arthroplasty. This is a patient which had uncemented THR for a type A DOR classification. This is uncemented again for type B. This is again for a type B, but this is a newer advancement. We have used a collared stem here. So this reduces osteopenia or what is called as stress shielding. And this is for a DOR type C. We have done previously cemented hip arthroplasty. The patient had come to us later with other hip fracture. As you can all see in this X-ray, the patient has a very narrow cortices and a well cemented implant inside it. This is another case of similar for a DOR type C, a cemented hip arthroplasty was done. The take-home message will be individualize the surgery according to the patient and DOR's classification. Type A and B, uncemented stem, type C, cemented stem. In young patients, plan surgery keeping revision in mind. Thank you.
Thank you, Dr. Ijajuddin. Now I call upon Dr. Arun Kannan for his talk on bearing surfaces, options then, now and future in THR.
Good evening, everyone. I once again thank the OSSAPCON organizers for having me here from Chennai. So we look at the bearing surfaces in THR in the past, present, and future. So three things I will concentrate on: what has become the past over the last 20 years and why. Second will be which is the best bearing that is in use currently based on current evidence, and what are the future promising options or option. So this was a state level TT player. He had achondroplasia and had both hips done at the age of 30 years in 1997. 14 years post-op, you can see how it is. He has worn through both his polys, and his femoral head has in fact broken the screw in the acetabulum. So this mainly I can say confidently now was the result of the non-cross-linked poly. So over the last 20 years, the most significant advancement has been the use of highly cross-linked poly. Any poly that is irradiated with 50 kilo gray is called a highly cross-linked poly. It has improved wear, but it also gives rise to certain other problems like free radicals from the radiation. So to reduce that effect, they are remelted or annealed, and this decreases the fracture resistance of the poly. But those are minor disadvantages. The major advantage has been the improvement in wear characteristics. So compared to a conventional poly, which we call the ultra high molecular weight polyethylene, the highly cross-linked polyethylene has almost 7.5 times lower wear rate. And at 20 years, this is data from the Australian registry, the revision rate for non-cross-linked poly overall was 18% compared to 8% with the cross-linked poly. So this translates into a almost 3 to 4 times reduction in the revision risk. So you can see with the non-cross-linked poly, the green graph is the reason for revision being loosening. So that was by far the #1 reason for failure with the older polys. With the cross-linked poly, you can see that it is only just among one of the other causes of revision. Other causes of revision have become more prevalent. It is almost, we can say that it has nearly eliminated osteolysis as a major problem in THR. So therefore, consequently, the usage has decreased. Almost all polys we use now are the cross-linked polys. However, we still have some local manufacturers as well as certain low-cost components that come with the old poly. Please do not use them. Check what poly you are using before you put in a hip. And I can confidently say that the old poly is definitely belonging to the past. It has no role in the current. Which is the best bearing today? Again, I will pull up on registry data because some bearings in some centers, in some hands, give good results. But we are talking about what is applicable for the community as a whole, and registries have a wealth of data regarding this. So the Australian registry is a very good source of information, has lakhs of THRs under their follow-up. And you can see at the very bottom, the bearings with the lowest revision rate. Those are the ceramic on highly cross-linked poly and the oxynium on highly cross-linked poly. Those have the lowest revision rates. Next comes the metal on highly cross-linked poly, and lower than that is the ceramic on ceramic, meaning out of all these, the number one or the lowest risk of revision is seen with oxynium or ceramic with highly cross-linked poly. We can have similar data from the UK registry as well. So it is not confined to one region, but it is seen across registries. So why this combination is proving to be very good? As I said earlier, excellent wear properties. They are more scratch resistant, especially with the highly cross-linked poly. If you have scratched metal heads, they give rise to more wear. Oxynium as well as ceramic have very good scratch resistance, so they have better properties once the head is a little bit worn or has some issues. Even then, it does very well with the highly cross-linked poly. The more talked about but less prevalent thing is trunnianosis at the head and neck junction with metallosis, and use of ceramic or the oxynium material avoids this, and it's a very forgiving bearing unlike the ceramic on ceramics. Ceramic on ceramic has been an illusion for a long time. A lot of us think or have been alluded to the prospect that it has a very, very low wear rate, which is true. It has very low wear rate, so it has sort of prompted many surgeons to try its use. But let's say a medicine has a side effect at 100 grams, and currently we are giving a dose of 10 grams at using the ceramic on poly combination. Ceramic is now reducing it to 1, but it doesn't give any practical advantage. And that is what we will see over the next few slides. And it brings along other unknown problems with the metal on poly or hard on soft bearings. One of them is squeaking. It is seen in about 3% of hips that have a ceramic on ceramic bearing. It is higher, more associated with younger age, obesity. Again, acetabular inclination. We always think we'll get a 45 degrees acetabular inclination or a 40-degree acetabular inclination, but out of 100 hips we do, 1 or 2 will definitely go out of that range. So it is less forgiving. If you put the acetabulum in malposition, ceramic on ceramic bearings are less forgiving. And certain brands again are associated with the higher incidence of squeaking. Ceramic fracture, it has become less pronounced with the use of delta ceramic, but it is still a problem. 0.2% translates to about 1 in 500 hips can have a ceramic liner or head fracture even with the newest ceramics. The reasons are incorrect seating of the liner, and again, acetabular malposition. Yeah, if everyone can get the acetabular position perfectly right every time, then maybe we cannot see this, but doesn't happen in the practical world. So this was a 50-year-old female. She had had a ceramic on ceramic THR. The surgeon was influenced to think that she was young and he would give her a very long-lasting hip. She had cup loosening from ceramic liner fracture and was revised elsewhere. They put in a metal on polyethylene bearing. But again, she had developed loosening of the acetabular component. And when we went in, this is what we saw. A lot of dark tissue, very similar to a metallosis or a metal on metal bearing surface. And the reason was this. There were ceramic particles that had been left behind in the previous surgery, and they had abraded the metal surface. Ceramic, mind you, is a very hard material, and when ceramic goes against metal, it is metal that wears out. And this is what happened to her. So this again is from the Australian registry. So ceramic on highly cross-linked poly and oxynium on poly perform much better than ceramic on ceramic combinations. Again, we think if where is the main concern, actually ceramic on highly cross-linked poly should over the long term do worse than ceramic on ceramic. But you see the difference between 10 and 15 years. At 10 years for ceramic on poly, it is 4.2, and it is almost similar for ceramic, 4.9. But at 15 years, ceramic on poly, it is still 5.8, ceramic on ceramic has increased. So it is not that wear reduction through usage of ceramic on ceramic is going to totally eliminate revisions for us. So I can say, based on the current evidence for today, ceramic or oxynium with highly cross-linked poly is the #1 bearing today. And it reflects over time in the usage. This is based on UK registry. The blue line is the ceramic on poly. You can see that over time, the usage has tremendously increased. Metal on poly has sort of maintained status quo, and ceramic on ceramic is the gray one, and it has come down with time. Again, registry trends show any new bearing that is being more frequently used. The upper one is the volume of THRs. The middle one is resurfacings. You can see that it clearly belongs to the past. Nobody is using resurfacings anymore. And the last column, you can see dual mobility THRs. They are increasing in number. Dual mobility bearings come with two articulations with a large polyethylene insert. And the main advantage is they reduce instability or dislocation. The reason being that because of the large head, they have a higher impingement-free range of movement, as well as they increase the jump distance. So the main advantage of a dual mobility bearing is the stability. So they are useful in certain special situations. For example, old people who are very active with femoral neck fracture, they are high risk of dislocation. This was one case where we used dual mobility bearings, and we continue to use them. And high-grade dysplasias, grade 4 dysplasia and grade 3 dysplasias, and one of the commonest reasons for failure is instability. And in these patients, dual mobility bearings is very useful. Then there have been a lot of big analysis on dual mobilities and with very low complication rates. Particularly would draw your attention to this one, where they showed that the wear in dual mobility bearings is not very high. And that is because most of the movement happens at the head, the smaller head and polyethylene articulation. As you can see very clearly in the video, the larger polyethylene is hardly moving. So wear in dual mobility bearings as of now doesn't seem to be a major concern, but the final word is not out. So at least if not for all patients, definitely it is not proven role in all patients, but patients at high risk of dislocation such as this, definitely there is a good role for a dual mobility bearing. So take home messages past is non-cross-linked polyethylene is definitely belonging to the past, as is metal on metal. Currently, the #1 bearing is highly cross-linked poly with either ceramic or oxynium. Metal continues to be used, no major disadvantage, but it is definitely #2. Ceramic on ceramic has been promising for a long time. We are yet to see its promise materialize. Future, I think there might be more use of dual mobility bearing, especially in high-risk situations. Thank you very much.
Thank you, Dr. Uday Krishna. Next talk is on THR in type 2-3 dysplasia. Dr. Uday Krishna.
Thank you, Chairman. At the onset, I thank OSSAPCON Ongole for inviting me here, and it's really a privilege to be here. Yeah. As one of my colleagues mentioned about the knee replacement regarding the valgus knee, this is a case where dysplasia is a bit difficult cases. What we operate, sometimes what happens is we think it's a primary knee, we enter and we'll end up in trouble. So my colleagues or my junior colleagues, what we always train, as we have trained ourselves, like we operate a good number of primary hips, then go for dysplastic hips, because this is not a routine hips to be easy to be performed. You should have a good armamentarium and good backup of implants on table.
So development hip dysplasia encompasses a spectrum of progressive changes on both femur acetabulum, especially soft tissues, which eventually lead to secondary OA of the hips. Total hip replacement is really challenged with high complication rates, especially the sciatic no palsy, dislocation, limb length discrepancy, and so many sort of complications can be expected with this DDH problem when you're treating with the THR in the primary osteoarthritis. What happens with the acetabulum issues? Acetabulum in this dysplastic is really shallow. So any dysplastic hip that has to be examined preoperatively in a proper template manner and check whether is it dysplastic or normal hip. When you found out on a clinical diagnosis, radiological diagnosis, dysplastia, then you should think of these terms. One is acetabulum could be shallow and different types. Then acetabular fossa or Harris fossa that can be expected on table to see it's very shallow or triangular part. Then it could be an excessive anteversion. For this, there is also some other issues with the femoral component where increased neck shaft angle, excessive anteversion, and small diaphyseal diameter and metaphyseal diaphyseal mismatch can be expected. So how do you classify? There are two main classifications. What we always thought about is Crow classification that is very commonly used. And of course, it has its own limitations. Second classification is Hautofilikidas classification. We'll go one by one. One is Crow classification. What it is? It gives you what is the proximal displacement of the femoral head in a superior to inferior direction. But it doesn't give any mediolateral or anterior posterior direction. That's where your navigation or some amount of robotics comes into place. So the Crow classification tells us that any amount of displacement, superior to inferior displacement, you can classify according to the Crow 1 is less than 50%, Crow 2 50 to 75%, Crow 3 75 to 100%. And Crow 4, it's type 4 altogether. My professor, Dr. Chandrasekhar sir, will be speaking about type 4 classification. In this Crow classification, this patient is around 27 years, female. She came to us with right hip is type 1, type 2 is left hip. So most important thing is you have to calculate the LE angle of Weberg, lateral edge angle of Weberg. What does it signifies? One, if you draw from the center of hip, one line perpendicular straight onto the ilium and one tangent line to that, which it crosses to the lateral part of the acetabulum. So it should be less than 20 degrees. Then it indicates that, okay, it is a dysplastic hip. If anything is between 20, there is a completely a dysplastic hip, the angle it is reduced to 20 degrees. Its normal is above 25 to 40 degrees. In the type 3, where it's more difficult, the acetabulum is more shallower and the anterior posterior, the cup size will be very small and the columns are a bit difficult to identify. So in this pre-op, we have to evaluate what is the angles. Again, in this angles, lateral edge angle is reduced and that has to be tackled before the templating. This is type 4, where completely the head is somewhere in the ilium with derotated and antiverted. It requires some sort of shortening. So the good part of the acetabulum is somewhere here. Your head has to get here. Instead, you have to do some osteotomy and get it here. So what the Crow classification has its own limitations. One, it tells us the superior to inferior direction that can be seen by preoperative templating, but it doesn't give us an idea of anterior posterior or mediolateral direction. That's what the main limitation of Crow classification. Over this, we have Hautofilikidas classification, where it gives some idea of what is the primary management or intrapathology. That's what it has its own significance. One is dysplasia type 1, where the head is within the acetabulums contained, only superior lateral defect is there. You can directly put a normal cup and come out. The problem comes with the type 2, where it's a low dislocation, where the acetabulum is very, very shallow, and you have two types of acetabulum. One is true acetabulum, one is false acetabulum. So on table, you should identify
and put a proper cup. And type 3 is very high dislocation. That has to be dealt with some sort of a trochanteric osteotomy or get it down and place in the normal hip. So this, I want to spend a minute here. This is very important. Center of rotation on table, how to recognize. This is very, very important. After exposure of 360 degrees here, this is a type 2 in the first center. Your first reamer should come very close to the inferior margin of the cup or the acetabulum, that is on the fossa, where either you palpate the inferior osteophyte or inferior capsule. Your first acetabulum or the first reamer should be very close to the inferior margin. If you go on reaping with the entire acetabulum, you land up in a very big size. So that should be avoided. That's what my point is. Second, in type 3 crow, it's much more lower. You identify all the ligaments, mainly teres minor, the ligament and teres, and inferior capsule that has to be identified. Keep the reamer. You take your help of the CM. If you don't have another support of navigation or robotic, then you can nicely place. Once you exposure, so most important thing is ream through basic or partially inferior ream. That is very, very important. Don't worry about your contact, anterior posterior contact should be good. Where the columns, it fits very well. Your less than 20% of uncovering should be forgiving. That's not at all issues. This is the technique where all primary, all my revisions I'll do without CM, but that has to be done with CM. That is very, very important. Your first reamer, it should be very close to the teardrop. See that this matches very close to the teardrop. It goes very inferiorly. So your first reamer should be from the posterior inferior to anterior superior. If you go from superior to inferior, you land up in a very big cup. Then you'll land in trouble. That's what the problem is. So there are a 6 o'clock position. You have to start the reamer from here. Slowly you enlarge it and keep it enlarging within the circle. If you come it from top to bottom, then you have a problem. So this is how the cup sits. The lateralization of cup should have a lot of impact on hip abductor forces. That should be avoided. Oversized reaming, that should be avoided. So what happens is when you put a acetabulum reamer on directly on from superior to inferior, you land in completely reaming of the entire ilium. That's what the trouble. Your cup should be very minimal and it should be places very close to the inferior margin of the acetabulum. So I have only 2 cases to show. So first case, 27 years old female. She is suffering from both hips. We targeted it from one after the other within a span of 3 months. So one is left hip. It's only a straightforward case. Only superior rim is dysplastic. We tackled it. The second one was type 2. It was a little bit difficult. So this is a pre-op X-ray showing a lot of anteversion in the femur, and it's very dysplastic. She has a spinopelvic deformity. We have to counter on table. If a spine deformity is there, see that your version of the cup should be reduced. This is a post-op follow-up within 3 months. She is done extremely well within 3 months post both hips replaced. So there's a second case. This is a type 3, bit difficult. Your acetabulum is completely shallow. It's almost a rim. It's only a rim. We don't have anything there. You should have all backups of the implant. As one of the colleagues have showed, like at least dual mobility, your backup armamentarium should be there all together, because we have only one chance. If you fail, you fail very drastically, because revising again total hip is very difficult. It's very cumbersome for the patient as well as surgeon. So in this case, it's a type 3. See the amount of head has got displaced so much. Your main idea to keep the acetabulum as close to possible to the near anatomical position. At least 2 to 2.5 centimeter hype center can be accepted. It's well proven. Our Ranabath group have proved at least 1 decade of hype center accepted. They have done really extremely well. So this is a post-op pick, 1 year follow-up. She's doing well. She's due for other hip. It's type 2. We're waiting for that. So finally, the take-home message is very important. Placement of cup in anatomical position is a key. Hype center, but never lateralization of cup. Pre-operative templing is must. Robotics may be a game changer in tomorrow. Anyway, my colleague, Dr. Adarsh, but be handling that. Type 2 and type 3 is really challenging. Why? Because we don't have any acetabulum there. So the placement of cup should be very, very careful. Identification of Harris fossa after exposure of 360 degrees is very important. Intraoperative reaming from posterior to inferior rather than superior to inferior is key. And a small cup size with the modular imprints are very, very imperative. Thank you.
Thank you, Dr. Uday Krishnan. I request Dr. P. Chandrasekhar to give his talk on THR in high hip, dysplastic hip.
Good evening. At the outset, I thank the organizers for giving me the opportunity. Well done, Uday. And then THR in the high hip or dysplastic hip. And THR in high hip center is difficult and challenging, because already Uday has told, the anatomical variations are there in both the acetabular side and the femoral side, along with the soft tissue contractures. Unlike OA hip, the THR in this DDH is seen in younger individuals. And in view of the poor bone stock, early revisions are relatively common. And then this should be discussed with the patient. Only to those with a severe hip pain and a failed conservative management, like shoe rise and abductor strengthening exercises, surgery should be offered. Surgery should not be offered for the sake of limb length discrepancy. And as already told, acetabular side tends to be smaller, shallower, decreased bone stock, anterior, superior, and lateral wall deficiency, abnormal version will be there. And then true acetabulum is filled with adipose tissue. It is difficult to find intraoperatively. And the femoral side, coxa valga, short neck, excessive anteversion, narrow medullary canal, and then abnormal limb length discrepancy. And this is, you can see, this is increased anteversion and the deformed acetabulum, and the greater trochanter is posteriorly rotated. And the soft tissues are contracted, adductor muscles become transverse, hypertrophy of the psoas tendon, hip capsule, and ligamentum teres and labrum. Sciatic nerve is also shortened. And already told by my previous speaker about the Crow's classification and its diagrammatic representation. And then this is the Arthroplasty classification is very simple and very practical. And you can see there is a dysplasia of the hip, and there is a low dislocation, and it is a high dislocation. And pre-operative evaluation basically includes noting the hip range of motion, limb length discrepancy, and then amount of trochanteric migration. This is very important, and the pelvic tilt. And you can see this is a pre-operative radiograph where we can see the conformation of the acetabulum, true acetabulum. This is the teardrop, just 5 mm lateral to the teardrop. Draw an isosceles triangle where that is the A is the starting point, and B and C are 20% of the femoral height. This basically, this triangle tells us where the real acetabulum is. And then this is another important thing, where the trochanteric migration. Trochanteric migration, this is the again the inter-teardrop distance, and the distance between the inter-teardrop line and the tip of the trochanter is known as the trochanteric migration. If it is more than 3 cm, then the reduction without an osteotomy or a shortening femoral osteotomy is difficult. So that is an indication for a shortening femoral osteotomy. So preoperative evaluation, CT shows us about the anteversion of acetabulum, and then the femoral, and then a combined anteversion. And coming to the implants, in acetabulum, the cemented or uncemented, both can be used, but you should be ready with bone grafts. And on the femoral side, if it is a monoblock, can be used in a dysplasia variety, whereas a modular or a customized stem is necessary for the higher anteversion and higher dislocations. So coming to the mild dysplasia, any standard hip approach can be used. On the acetabular side, identification of the true acetabulum and restoring the normal hip center is very easy. Reaming and uncemented acetabular cup fixation, and be ready with the small cups. On the femoral side, you can go for a monoblock stem. This is what Uday is explaining about. Basically, in a dysplastic hip, you can see there will be floor osteophytes, and the floor osteophytes will be very much widened at the floor. And you can see the head is lateralized. If you don't ream it completely properly up to the floor, your cup will be lateralized, having its own problems. So how to do the proper reaming? This is the deformed head, and this is the shallow acetabulum. And basically what we have to do is we have to know the depth of the acetabular floor. So just simply ream through a small drill bit and go to the floor. Then you will know how much is the depth of the acetabulum. Then you can ream that much depth. You have to go down so that you will medialize the cup. And then this is at the end of the acetabular reaming. And you can see still there will be some uncovering. Up to 15 to 20% of the uncovering is accepted. And this is the post-operative X-ray. Coming to the low and high acetabular dislocations. The posterior approach is the common approach being used in this case. And a lot of soft tissue releases you have to do, such as adductor tenotomy, and sometimes an iliotibial band release, an iliopsoas release, and then piriformis hamstrings. And sometimes you have to do a shortening femoral osteotomy. On the acetabular side, identification of the true acetabulum is very difficult, and you can use a ligamentum teres as a guide, or an inferior capsule which aligns with the tal, and certain bony landmarks, anterior and posterior walls. And then we don't hesitate to use fluoroscopy. This is the case basically showing the Crowe 4 type 4. And you can see the deformed head. Not always a ligamentum teres will be attached to this. So approaching the true acetabulum will be always difficult. And in this case, basically, even for approach, for betterment, we do a femoral shortening osteotomy. And then a smaller diameter of the cup is necessary, and controlled reaming to deepen the cavity should be done. Arthroplasty, that is osteotomy of the medial acetabular wall to medialize the cup, will be done in some cases, but the problem is the medial migration of the cup. Bone grafting, one should be ready, and cup position, you should be taking the local landmarks into consideration, and the cup, the anteroposterior capture is the best guide, and you may not get a superior inferior capture, and you should be ready to put a bone graft on the superior wall. And on the femoral side, there is increased anteversion and high neck shaft angle, and then modular stems are adjusted and used to adjust the anteversion, and the monoblock stems are not preferred in this case. And you can see this is an intraoperative, basically doing a trialing of the case. This is the postoperative case where we did an osteotomy and then fixed with a modular stem. And what is this femoral shortening osteotomy? While reducing the high hip to the true acetabulum, if there is more than 2 to 3 centimeters or 4 centimeters stretch you have to give, then it will cause a deleterious effects on the neurovascular and the periarticular structures. And to address this, a femoral shortening osteotomy is necessary. The advantages of femoral shortening osteotomy are, if there is any malrotation already present in the shaft, that can be addressed, and it facilitates easy exposure and easy reduction, and it prevents neurovascular traction injury. The level of osteotomy is again depending upon the trochanter, trochanteric osteotomy, subtrochanteric osteotomy, or a distal femoral osteotomy. And subtrochanteric osteotomy, to increase the exposure, for better exposure and for early easy reduction, you can do a subtrochanteric osteotomy. Types of osteotomy, there are different types, a chevron type and transverse type. And then transverse is easier and simpler. And what you have to do is you have to do 2 osteotomies. One is the site of the first osteotomy is just 1 to 2 centimeters below the lesser trochanter. And the second osteotomy is once this acetabulum is completed and put a prosthesis into the proximal fragment and reduce the joint. And the overlap between the first and second fragment is the amount of osteotomy to be done. This is a case 1, a female 43 dysplastic hip, and you can see the acetabulum and the deformity. This is where we had done a supracanteric osteotomy and fixed with a modular stem. And whenever we do a bigger osteotomy, we have to take a bigger osteotomy, then the stem support will be less in the distal fragment. That's why sometimes to prevent the rotation, we use a plate. And this is at the end of the 3 years. Well fixed stem and no loosening. And this is another case where a female is dysplastic hip. And you can see here the true acetabulum is very small and shallow. And this is at the end of the preparation. You can see very flimsy anterior and posterior walls. So we did bone grafting with the same femoral head which we have used. And this is the preparation. This is at the end of the surgery. And we can see the osteotomy and the fixation with the plate and the implant. This is another case where a female 28 years with the dysplastic hip. You can see even on X-ray, the dysplastic acetabulum is very small. And when we have opened, the true acetabulum is very flat and there is nothing like a acetabulum there. And it is not feasible for a cup placement. Then we have to go for a superior reaming. And this is the end of the superior reaming and then fixation. This is how we ended up having superior acetabulum. And it is biomechanically desirable always to keep the acetabular cup in the true acetabulum to restore the normal hip center and mechanics, but it is not always feasible. And it is supported in the literature that a high but not lateral position is acceptable. So in conclusion, high hip center, total hip and hip center is technically demanding. A diligent preoperative planning is essential. High risk for dislocation and early revision should be discussed with the patient. Intraoperative use of fluoroscopy, supracanteric osteotomy, and bone grafting are useful tools. Restoring the native acetabulum and normal hip center is biomechanically desirable, but not always feasible. Thank you.
Thank you very much, sir. I request Dr. Adarsh Reddy to deliver his talk on robotics in hip arthroplasty.
Thank you, sir. Wonderful talks by the previous speakers. So covered most of the gamut of hip replacement. So again, I'm here again to speak about robotics. This is, excuse me. The presentation mode. Maybe. Just a second. Yeah. Yeah. Sorry for that. So I'm speaking about robotics again, but now in hip arthroplasty. So again, just like how I started my previous talk, again, THR is one of the most successful procedures in orthopedics, and it's evolved significantly since John Chanley's low friction arthroplasty. There's so many advances like spoken by a previous speaker about implant design, the material science, coupling options and bearings. And of course, the latest innovation is probably robotics. So the THR is the forgotten joint. It's uniformly great results, good forgotten joint scores, and the surgeon feels that he can do nothing wrong. So a hip surgeon is usually this, he's a Superman. But what about the variables? So then there's so many things to think about: the cup antiversion, inclination, the size of the cup, femoral sizing. And then of course, if you put the cup in a wrong position, you have so many variables here, excessive anteversion, retroversion, excessive inclination, horizontal cup, all these things can cause again different problems, different kinds of dislocations. So then the surgeon starts to feel a bit wary. He's no longer feeling like a Superman when you think deep about it. Then even more, if you think there are even more variables, cup depth, cup height, the bone stock, limb length discrepancy, offset, and there are so many different things that can go wrong. If you have a high center of rotation or low center of rotation, it affects the biomechanics. So again, this is what, if you really think deep, this is what a hip surgeon really should feel like. It shouldn't feel like he's a Superman. So as I said before, improper cup positioning can cause a lot of problems, impingement, restricted ROM, dislocations, and abductor muscle strength also can be reduced, leading to abnormal gait. So when you go for accuracy in a total hip replacement, traditionally, the main parameters that we look for are the acetabular component and the femoral component, that is anteversion and inclination. And femoral component is again anteversion and restoration of the offset. When all the studies show almost 50 to 75% are outside the target zone that we see in literature. And in femoral component, almost 20 to 30% are outside of the target zone. So that's quite a big number. So what are the tools for optimum cup positioning? So obviously pre-op templating is very, very important, like as spoken by the previous speakers. And intraoperatively, you have different things that can help you to check out what is the right position. So templating, it is very important, but it can also be a little bit confusing. So you have so many lines to think about and so many things to figure out. And of course, there's the transverse acetabular ligament technique. It can be used intraoperatively. But again, this can vary from patient to patient. So it's not a 100% reliable thing. So if you think about it, there's a huge algorithm that has to be planned out and a lot of tinkering has to be done to get all these things: cup size, femur size, cup height, cup depth, center of rotation, anteversion, inclination, offset, limb length, and bone stock. So what if you can accurately address all of these at once? So now you can with the robot. So again, this is not the only way to do it, but it really makes our life much simpler. So just like the knee and the preoperative CT scan is required here. So again, talking about the Mako robot, it's the only one at the moment which can do the hip replacement. So you get the CT scan done, and then you help, and then you do your registration of the bones to map the CT scan onto the real life bone. So you get the patient specific planning is done. So you get all the points on the femur and the acetabulum. And then once you've mapped all this out, it tells you exactly where is your cup in real time. It helps in your neck resection as well. And of course, the stem placement. Okay, and anteversion of that. So the OR layout here, the robot comes from the contralateral side, from the other side of the surgeon. And the brief workflow, it's quite similar to the knee. You start with the planning, the landmarks of the patients are placed, then the pelvic arrays are placed in the iliac wing. You have to verify your checkpoints and do your registration of the acetabulum. Then you do your reaming. It is with the help of the robot. And of course, the femoral preparation, trial reduction, and the reduction results you can check on the screen. So implant planning is the first most important advantage of the robot in the total hip replacement. So here we're moving from a 2D manual planning to a 3D model based planning, because till now we were planning a 3D hip on a 2D template, but now you actually have a 3D model and you can get the exact anatomy of the patient. So I'll use this X-ray, this particular patient as an example for all the advantages. So we have a right hip arthritis over here. So first amount of information we get is a 3D reconstruction as well as a pre-op limb assessment. So we know that we are 3 millimeters shorter than the opposite side, and we have a 6 millimeters excess offset, increased offset over here. So these are some things that we get to know beforehand itself. Then we can do a little bit of planning. We can say a 44 cup with a size 2 stem, 127-degree neck. And by doing all of this, we can get an equal limb length. And this will show you how your hip is going to look. This is all done even before we enter the theater. Okay. Then again, we can plan the cup. The cup you can plan in the 3 views. The transverse view, you can see the good anterior-posterior fit. You can see it's nicely matching your bone. You can see in the sagittal view, the superior-inferior, as well as the coronal view as well, to make sure that you're getting a good fit in all the 3 planes. And we can again determine our inclination and cup version right over here. If you feel that your femoral anteversion is less, you can increase your cup version right here. Then you can restore your center of rotation. This pink dot is the native center of rotation, and the green dot is the center of rotation of the cup. If you feel you need to medialize, you just medialize it, and you can just get your center of rotation a little bit more medial than you usually do. This is just a rotated view of the same thing. After that, you can check your femoral component sizing as well. So this shows you what is a good fit. A size 2 is a good fit. With a 127-degree neck, we're getting a good offset. It is almost matching the opposite limb. It also tells you what is your version of your femur. I feel one of the best parts is you get a pre-op visualization of the post-op X-ray. This is not a post-op. This is just going to show you this is what your X-ray is going to look like. 99.9% of the times our X-rays are absolutely the same as this visualization. So again, the brief workflow I mentioned, the bone registration, the initial registration, you have three major points which give you the overall, the rotation of the particular acetabulum. It gives you the whole layout. And then you have to do the multiple fine points. Again, this hardly takes 2 to 3 minutes once you get used to it. The reaming is done with a single ream. Once you've determined your cup size is 50, you just do a 49 ream and that's it. Single ream and you're done. And then you go for your impaction. So this is how it looks. It goes in auto alignment. So now we don't need to do the sequential reaming anymore. Once you've planned everything, you do a single ream and you save time and you also save bone. You're not going to unnecessarily ream excess of bone. If you see over here, sorry, yeah. You can see over here now, registering the point. Now you see the green part is what has to be reamed out. In the corner over here, you can see the actual reamer in. I can move my hand around. It is not locked in over here. It's a funnel haptic. So I can move around depending on where I want to ream. So if I want to go more superior, and these numbers show me where I need to go. More superior, more medial, more posterior. And once you start reaming, you start getting rid of this green portion of the bone. That's it. Do our single ream and we're done. Okay, once you get to 0 on all the 3. Then of course, cup impaction. Again, we stop trialing now. Once we have our proper reaming is done, we take our final cup on the impactor and there's a single shot. So you can see over here, I put my final cup on the impactor. And this is also going to tell me how many more shots I need to hit, how much more proud I am. So if you see, I'm going to hammer and capture the numbers. I'm hitting and you can see I'm 5 proud. Okay, and hit it again and capture. I'm 2 proud. 1 more shot. 1 proud. 1 more shot. And I'm completely fixed inside. So that's the beauty. So you don't even have to go for trialing now. Okay. Again, once we go to that, we go to the femoral preparation. And here, once you've actually put in your cup and then you put in your trial femur, you can even check whether you're matching. So what we planned is 40-20. It will tell you if you're actually matching it or not. And it also tells you what your length and your offset is going to look like. Okay. So as I mentioned, so this is that same, our case, 39 degrees and 22 degrees is what we got. This is very close to what we planned. We can get even more accurate if we really try hard. As I said, we already know what the X-rays are going to look like. This is a pre-op X-ray. This is the 3D reconstruction. This is a pre-op visualization. And this is what the X-ray looks like. It looks exactly identical. You see the cup over there. What about the procedure time? You may think that with the registration, it's going to take longer, but actually now it's hardly taking any time and we're reducing time in reaming and impaction. So our time in the total hip replacement has actually come down by almost 5 to 10 minutes. What does it mean for the patient? Again, reduced surgical time and blood loss, unparalleled accuracy, restoring the limb length to pre-pathological state, smaller incisions, and reduced trial and error and subjective feel by the surgeon. What about the future? Upcoming software allows us to recognize hip impingement as well. It's going to help us adjust for abnormal spinopelvic anatomy. And it's going to help us assess the combined version of the THR components. Just a few examples. This is a bilateral case, just to show you how close we match our pre-op visualizations with our X-rays. It's almost identical every time. And Dr. Chandrasekhar and Dr. Uday had given a lovely talk on dysplastic hip. We can even use it here. Here, the most important thing in a dysplastic hip is where is the good bone stock. It's going to tell us where the good bone stock is. We can plan it out nicely. It gives us a pre-op planning. And you can see that we can almost match it 99% of the time. It's very beautiful. You don't have to worry where is the exact bone stock. You see it beforehand. You could even use it with previous implants in situ. You can see whether the screws are going into the acetabulum or not. And you can see this particular case. This is what the pre-op visualization. We managed to take out the screws and do a good case. In this particular case, there was an acetabular plate. And we were worried whether we need to take out the plate or not. But just by planning, I brought my cup down by just 2 mm in the planning itself. Then I managed to go ahead without removing the plate. I just don't want to bore you with the literature. It's showing that very good accuracy with the robotic hip and much less amount of pain in the literature as well. Okay, so as you can, percentage of pain or little pain is much less in the robotic cohort. People who are saying no pain are much higher in the robotic cohort after 6 weeks. So this is the outcomes in the robotic total hip replacement surgery. Thank you for that opportunity.
Thank you, Dr. Adarsh. I request Dr. Uday Krishna to deliver his talk on THR in failed intertrochanteric fractures.
Thank you, sir. Thank you again. This is my last talk of the day. It's really a nice session on the hip with good topics selected. So, it's the most difficult surgeries where you have an implant and you go for hip replacement. It requires a lot of planning. Doing a PFN or a DHS for some fractures like IT or stable, it's easier. But doing CC screws or to conserving, it's really difficult. To revise, it's the opposite. If any implant is there, like a PFN or DHS, to revise to total hip is more difficult than screw removal to do a THR. So it's a bit thing. I mean to say that when you do a PFN, you know, the mortality is very high. The patients are elderly, 78 years, 30 to 40% mortality is there. They're already weak. If that implant fails, doing a THR is really cumbersome. So my topic is THR in failed intertrochanteric fractures, where total hip replacement as a salvage treatment for failed IT fractures in elderly significantly reduce hip pain and restore joint function, especially early recovery and satisfactory. What are the challenges we have here? Most important thing is elderly age, severe osteoporosis, underlying infection could be there. You have to rule out all them with markers, bone loss, soft tissue contracture, and especially bone defects. There are two examples here. One is DHS done elsewhere outside. The screw is completely cut out, but they waited too long, at least 8 to 9 months to come to me. So by the time it is there, completely bone loss is there. So revising this, it's really a challenge. And second case is a failed PFN. It's really a difficult thing. I'll go by case-to-case example. It's easier for us to understand. It's a 58-year-old male and history of trochanteric fracture. He says he had fall, but we don't know. He's a diabetic, hypertensive, alcohol withdrawal. So the pre-op X-ray shows that it's a GT fracture, maybe a reverse oblique extending down, and we have taken full-length X-ray showing the X-ray is extending well below the subtrochanter. So somehow we felt that, okay, patient is having severe pain, maybe it's healed or no, we'll go for CT. But CT has a clear picture, showed that the patient also had a neck fracture. So your selection of implant gone wrong. Like instead of a cephalomedullary, it went on intermedullary. So once a patient has a neck fracture with implant in CU and 2 to 3 months old, the only option is to leave total hip. So we went and done a total hip on this with dual mobility cup. I was not sure whether how the abductors are there because already done previously hip. So it's a follow-up of nearly post-op follow-up this one. And 8 months follow-up, it well healed. The patient has good abductor strength, some amount of lurch is there, and is almost pain-free. Yeah, second case, 62 years old female, history of DHS for unstable trochanteric fracture done 1 year ago, came to us since 10 months. So this is a picture I've shown in the beginning. So in this type of pictures, you should always think of any infection. First, you rule out completely the infection. If you see here, there is no bone stock, nothing is here. Completely, the femur is gone. It's only a paper soft. If you compare to the opposite hip, acetabulum, we don't know whether it is a discontinuity of the hip or the screw, we don't know. So we need to evaluate properly, do a proper CT scan, and all the blood markers should be done. You should always keep implants, extra implants, modular implants backup, and plan for this. Only one shot treatment should be there for her to have a replacement. you can't remove the hip and do a girdles because patient wants some amount of mobilization. For the hardware, we're gone for full long stem, checked AP lateral views, and she is doing absolutely well. This is 3 months follow-up. Started the full weight bearing with walker, and this is 8 months follow-up. She removed the walker. She's walking on single cane. So for these cases, what happens is if the bone stock is so poor, abductors mechanisms are so weak, it takes very, very long time to leave the stick or walk. At least in the lifetime, they have to use some sort of support. So your selection of implants and the failure of the implant, that has to be identified properly. This is case 3. The PFN unfortunately got infected, done somewhere else. They have done a cement spacer also. They came to us. So we have done a total hip. My junior colleagues, or what we have learned, the experience is most important is to bypass the last tip of the stem here. The total hip was done here, but it didn't bypass the stem. So what happened? It got fractured. So lessons to be learned is whatever the previous implant is there, you try to bypass with the long stem. That's what my point to be taken from my junior colleagues. If that is not going to happen, already the patient has done two surgeries, some sort of small trauma. Again, this could happen. Exactly the fracture happened at the distal part of the tip. So we need to again to plate it, some sort of plate to fix it, to get it an anatomical thing. But a lot of cumbersome for the patient as well as surgeon to revise this sort of implants. Again, the last case, 70 years old female, sustained IT fracture, iliac wing, acetabulum was intact, and we have done plating. And patient was, this is a pre-op X-ray, completely shattered IT fracture, 4-part type, and iliac wing. If you see the iliac wing also gone near the dome. We have done a good-looking okay PFN. Iliac wing was fixed. The patient followed for 6 months. Suddenly, we don't know what happened. The screw started backing up. But at the time, we don't want to revise. Maybe because her medical condition was not, because he had some liver cirrhosis. We postponed. And at the end of 4 years, luckily the fracture united, but implant failed. So we need to revise in a cemented hip. And luckily done well. So at the end of the day, most important thing is your revision has to be there in a proper way with all implants on table, and do it in a systematic way. So take home message is, it's a very challenging to perform a total hip in failed IT, especially if you see an osteoporosis case where you can have a trouble on table where you might fracture a femur. You don't have any implant. So long stems backup should be there. Underlying infection that should be ruled out. Severe bone defects, either acetabulum or from the femoral side. You should have all the backup stem, all the augments, and the long stem should be there. Modular implants are backup, especially for the long stem. Risk of complications are very high. Thank you.
Thank you, Dr. Vinod Kumar. So very good and very informative session. Now it is time for discussion. Any questions from the audience?
A question to Arun. Is there any comparative studies between dual mobility and oxynium bearings? Which one is the best?
So there have been comparisons between dual mobility and ceramic on polys. The ones I showed was between ceramic on poly versus dual mobility. The wear was similar or slightly lower the dual mobility wearings in a simulator study. As I said, as of now, the wear doesn't seem to be very great of a concern. But again, if you look at registry data to see whether dual mobility is doing well or oxynium is doing well, it will be impossible because we are using dual mobility mainly for high-risk situations. So if you look at registry data, dual mobility will over the term show poorer results as compared to a single bearing. It has to be a randomized or short clinical study with controls, because dual mobility right now we are using only for high-risk situations most of the time. Wear rates as it is are seem to be fairly under control. We do not, right now, based on the data, we don't have anything to say that dual mobilities are going to bear out faster than the single mobility bearings. We can use oxynium head with the dual mobility also, or a ceramic head with the dual mobility.
The oxynium is available in India. Do you use it?
Yes, sir. I mean, that is the other problem with the oxynium. When I say oxynium, so it is available with Smith & Nephew, and that is the only company having it. So Australian registry, it shows the lowest revision rate for oxynium with highly cross-linked poly. But we do not know whether it is just because the entire combination is good, meaning the cup, the stem, and the oxynium with poly is good, or it is the oxynium poly alone which is leading to the better results. We have oxynium in India, Smith & Nephew provides it. So definitely it is not inferior to ceramic on poly is what we can say based on the registry data. But to say that oxynium alone is conferring the superiority might be a little bit of an overtake because it is manufactured by a single company.
Thank you.
Thank you. So I had one question for Dr. Uday. So in CRO 2 and 3, what's your routine approach? Do you go and try the high hip center, or do you try the anatomic hip center? Which one do you try?
Yeah, we all learn from Dr. Vijay Bose sir, like we have been associated with him since long time. So always try, especially type 2 and type 3, it's very difficult. Why? Because we have a very small acetabulum, like anterior posterior, we have only a small acetabulum when we open. The entire the false acetabulum is superiorly. So it's like egg has fallen anteriorly. So when you put a reamer, because I myself faulted, like put a reamer in the false acetabulum, what happens is we'll try to remove the entire rim of the acetabulum. So you need to identify with the CM images and properly take your time, put the, expose the inferior column or inferior border of the this osteophyte and expose and do it. Type 3 is very difficult. Why? Because we have a lot of bone loss is there. So in type 3, I feel that we can go up to 2.5 centimeters little hip center compared to type 2 and type 1, because a lot of bone stock, especially 1, 2, and 4 are in the native acetabulum. But type 3, a lot of defect is there. You can go for higher hip center, especially type 3.
Yeah, I mean, just asking what your routine approach was. So you generally prefer a high hip center and
see, my aim is anatomical center only. If I am failed in this, I'll definitely go for high hip center.
Okay.
Always best is anatomical hip center is better.
I agree. Yeah, there was one study from Dr. Fering's group. I mean, that is, I think, the only clinical comparative study between these two positions. Yeah. And they have shown better survival with anatomic centers than high hip centers in CRO 2 and 3.
Yeah, see, in the studies from HSS, especially Ranawat group, when we always interact that why high hip center? Because what is the take on that? Because they have all cases in all CRO type 2, 3, or whatever the cases, they go for all high hip centers. So their highest follow-up is nearly 12 years. They're doing extremely well.
Yeah, I agree. I mean, high hip center is not bad, but when you compare the two, there is the only study available.
Yeah, that's what try for anatomical. Yeah, and if it fails, high hip center also acceptable.
Yeah, I agree.
Thank you.
One question to others: how do you select the patient for robotics? Is it patient choice, or is there any criteria for it?
Yeah, it's a patient choice. Any patient can get a robotic hip. If they're affordable, they do go for it. So there's no restriction there. So sometimes we may find it difficult in a completely fused hip because we need to take registration points in the acetabulum. So we cannot cut it and then do it. But we have come up with a way to circumvent that also. We take the registration outside the acetabulum. So, but that's probably the only place we can't do it. Otherwise, any patient can get a robotic hip.
Is it any role in dysplastic hips?
Yeah, of course. As I mentioned here, it shows where the bone stock is best. So in fact, I would say the maximum use is in the dysplastic hip. Regular straightforward hips is not much of an issue. But dysplastic hips, you can actually get away, where is the bone stock. You don't have to guess it, where is a better place to put it. Before going in itself, we know that either we're going to put a higher hip or a native hip center, depending on the bone stock by seeing beforehand. So.
Thank you.
Shall we close the session, sir?
Yes. Thank you.
Yeah, thank you. May I invite all the speakers of this session, Dr. N.V. Sivaramakrishna, Dr. Ejazuddin, Dr. Arun Kannan, Dr. Uday Krishna, Dr. P. Chandrasekhar Garu, Dr. Adarsh Annapredi, Dr. Uday Krishna, again. Please come out to the dais. Kindly accept our token gift and certificate of participation too. So we would like to felicitate our chairpersons, Dr. Sunand Kumar Reddy Gargi and Dr. Vinod Kumar. And we would like to felicitate even Dr. P. Chandrasekhar Garu also. One more shot. Sir, case right. Thank you all. And the next thing that is on today's program is a general body meeting for the OSSAPCON. And before that, I would like to announce that our banquet is being held at Nalluri Gardens, Kottapatnam. We are running about 4 buses from here, right from this venue. It'll take you down there. And then you can come back in those buses also. And the buses will be starting roughly around 6:30, you know. It will be from this venue only, from A1 convention. It will reach the Nalluri Gardens. They'll wait for you and then they'll bring you back. And you can request the driver to drop you at your respective hotels, you know, like how you can con your patients, please con the bus driver also. Of course, we have given him instructions to do that. So I think it's time that OSSAPCON enters the picture. So chairs.
Thank you, sir. I think it's customary for us to have a very quick general body meeting of our association. Without much delay, we'll just start off with a small agenda. We'll finish off and then we'll join the banquet. You can have 5-6 chairs and tables. So I request our Honorable President, Dr. Y.V.K. Durga Prasad Osa, to come on to the dais. two more chairs, Krishna. I also request President-elect Dr. Dharmarao Garu to come on to the dais. Our Joint Secretary, Dr. Mopathi Srinivas, to be on dais, and Treasurer, Dr. Amarnath Reddy, to join us to the dais. The organizing chairman of OSSAP 2022, Dr. Malyadina Garu, and organizing secretary, Dr. Jayashekhar Garu, to come on to the dais. So this is an official meeting of OSSAP. I request the non-members of OSSAP to please leave the hall. This is exclusively for the OSSAP members. Those who are not members, I request them to please leave the hall. Malyadina, yeah, we'll start or wait for you. We can start. Yeah. ఎవరు సో వీరే చౌదరి గారు ఒకసారి స్టాల్స్ దగ్గర అనౌన్స్మెంట్ ఇస్తారా? జనరల్ బాడీ స్టార్ట్ అవుతుందని. దానికి ఏ మైక్ యూజ్ చేయాలో తెలియదు. వస్తా పొంగోలు. ఓకే. So OSSAP general body meeting is about to start. All the members who are at dining hall can come and join the general body meeting. Those in the industry area also, please join the general body meeting. So, shall we start, sir? The permission of the chair, we are going to start the general body meeting. All the non-members of the association, please leave the hall. We are about to start the general body meeting. So, I request our Honorable President, Dr. Vaidika Durga Prasad Garu, to welcome the general body meeting and start the proceedings.
Good evening. I welcome all the members of OSAP to this general body. Last year we could not have full general body. This time we are having not. Can we call the forum again?
Is sufficient. We have waited for the quorum. So, general body approves the quorum is sufficient to start the general body meeting. I will start the general body meeting.
Yes.
Quorum is okay.
Naresh, go ahead.
Yeah. Operate from here. Okay. So this year we have lost few of our beloved members. Dr. Venkat Subbaya Garu on 28th of March 2021, and we lost Dr. V. Ramana Rao Garu on 4/5/2021, and Biram Samsturao Garu from Vijayawada, and Dr. Hari Babu Garu and Dr. Lazarus Mukherjee Garu. To pray the respect of the departed souls, so I request all the members to rise for observe a minute of silence before starting the proceedings. Thank you very much, sir. So if any of the members know any more of our members who have departed, you can just list them out. So none were there. We'll proceed on to the Secretary's report. Secretary's report I briefly presented yesterday. Same thing will continue on. We started with taking over charges at Anantapur. And we had our first EC meeting on 28th of March at NRI Medical College. And our membership strength this year grew by 160 new members. Most of them are PG students and also consultants have joined. And total membership strength is 1,002 at this point of time. And we had the elections and Dr. V.V. Narayan Rao unanimously elected as a president-elect, incoming president-elect 2022. And we have started the fellowship programs. The fellowship programs, we had a call for institutes to enroll into the fellowship programs. And then we made an application form for the institutes to enroll. Once the institutes were enrolled, we called for candidates to apply for the fellowships. And the written test was conducted. This was the call for the memberships, call for the applications. And we had institutes in trauma, spine, arthroplasty, and arthroscopy. And the candidates who we received applications for arthroscopy, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 applications for arthroscopy, and 13 applications for joint replacements, and 7 applications for spine. And we had maximum number of applicants applying for trauma. So we had to conduct online exam. So 50 MCQs questions were given with 1 hour time. They were answered online with a software, Proctor software, where the movements of the candidates are also being observed. And our EC members and our president and past president have actually personally also supervised the conduct of exam. And the mark sheets were given. These were the list of mark sheets for each candidate for the fellowship for joint replacement, arthroscopy, and spine. Basing on the merit of these marks, then they were called for interviews. In the interview, the candidates were called in a order of merit, and the candidates were asked to choose the institution. If the center and the candidate were mutually agreeable, so we took the candidates for fellowship. The fellowship program. President, you want to say something about the fellowship programs? So we have few of our trainees and also trainers here. And many institutes are also wanted to join in the program. And so we're going to call for a second batch of fellows immediately soon after this postgraduate exams finishes.
Because of some lack of communication, many institutes have joined. This time we want to overcome that one, and we're announcing the call for institutes early, so that many institutes can join.
So we'll come out with a call for accreditation for institutes again. For any more institutes want to provide training to our younger members, they are welcome to join. And this is like institute has to pay 50,000 rupees to the candidate, and candidate will work for a year. And there will be a compulsory thesis allotted to the members, and there will be exit interview or exam kind of a situation once the candidate comes out of the fellowship. So we want to have a 3 months overlap with each cycle. So that we'll start the selection process 6 months before, and then candidate will join 3 months later, so that the senior and junior fellow will have a continuity, and that program will run comfortably. So we have Santosh, one of the course program directors from Ongole for trauma. Santosh, you can share some of your experiences of, you can use the mic or you can come over here. From Visakhapatnam. He has 2 trauma fellows. Use the mic. So how is the program and how are you comfortable with the fellows and how is it running?
So good evening, sir, all the dignitaries. First, I think it was a very good initiative, and program is nice, sir. We have been through the interview selection process and all. So we have allotted thesis. So we have been running classes. So initially we had communication in the trauma group as well as to how the progress was. Nowadays it is not so frequent. So it's going well, sir. So we are just waiting for the next batch of fellows. Only request is maybe if we can have if all the centers offering the similar kind of fellowships, like suppose all the trauma centers and all, if we can have some online meet or something, we can just see where we are going, and maybe if at all we need to make some changes and progress in the fellowship, maybe we can do that. That's the only thing I want to ask.
So that's what the pipeline, the orders, like we need to have a syllabus for these fellows.
Yes, sir.
The core competency, what they should be gaining at the end of the fellowship, and that should be uniform across the institutions.
Yes.
Maybe you mentors have to sit together and finalize the program.
Sure,
if you
sir.
want to take the initiative, that's more welcome to do that.
Yeah, if it's okay, I'll take the initiative and contact the other mentors.
Yes. For trauma, you can do that.
Trauma.
If any of the trainees are here, they can also share their experiences. I don't see any of the trainees here.
They should submit the paper also.
Yeah, they should do a thesis work, and that should be presented, and recognition of OSSAP as a fellowship will be has to be maintained. So coming to, so after that is a treasurer's report. I ask our Honorable Treasurer, Dr. Amarnath Reddy, to present the treasurer's report.
Good evening, one and all.
Treasurer report from the 1st March 2021 to 28th February of 2022. And we have the opening balance of 38,50,131 rupees 99 paise. And income we had in this year, amount received towards membership fee, 2,80,000 rupees. And Johnson towards OSSAPCON 2021 hybrid meeting, 4,43,250 rupees. And expenditure we had district club hybrid meeting expenses around 3,30,000 rupees. OSSAPCON 2021 hybrid meeting, online webinars and online voting 2021 charges are 1,89,000 rupees. And also monograph printing charges 10,270 rupees. And Guntur tours and travels we paid around 32,530 rupees. And for the preparation of medals 15,530 rupees. And payables of Professor M. Ramon Rao cash price is around 10,000 rupees. And farmer OSSAP executive pending salary around 30,000 rupees. And receivables are Johnson towards OSSAP monograph volume 3, 2 lakhs rupees. And donation from OSSAPCON 2020 organizers still it's pending. And donation from OSSAPCON 2021 organizers also it's still pending. And closing balance we have around 41,33,865 rupees 39 paise. Thank you.
Thank you, Amarnath. So ours is a association. We don't have a fixed source of income that we should say. The only source of income is through membership, which is just 2,000 rupees per lifetime. And second thing is only the contribution from the organizers of OSSAPCON is the only source of income. And for all the programs what we are offering, we are trying to get sponsors for that particular program. Like we wanted to do monograph, so we contacted a particular company to fund it. Similarly, whenever we want to do a cricket league, so we didn't use a single pie from the corpus fund of association. That has been kept as it is. For any new initiatives, we are just raising the funds and doing it. So there was a proposal in the EC we had. We need to take, this is the time just to increase the membership fees. 2,000 rupees is for a lifetime for orthopedic surgeon membership is something which needs to be really reconsidered. So we just had interaction with the Maharashtra Orthopedic Association, and their membership fees is 5,000 rupees. And Tamil Nadu Orthopedic Association is 4,000 rupees. So we were at 2,000 rupees. The proposal from the EC is to increase up to, so President sir, can you say? Do you want to propose the hike of membership fees?
Yes, we want to increase the, we decided to, EC has formed an opinion to propose increase of fees from 2,000 to 4,000 rupees. If they want to join IOA also at the same time, then we should give a reduction of 1,000 rupees. That is, IOA fees is 5,000, and if they want to pay together, it will be 8,000. 1,000 will be borne by the state OSSAP body.
Vinod Kumar sir. So one mic on the floor, please. Floor.
Sir, I think we can make 5, sir. Because our local club membership also, district clubs memberships also, they're keeping a minimum 4,000 to 5,000. This is our state body.
Okay.
It's for our fraternity. Our fraternity should, our association fraternity should be strong. 5,000 is not a big amount. It's a lifetime.
But what
That's my opinion. It's a seniors.
Yes, yes. Actually, EC is also the opinion that we should also increase OSSAPCON contribution also.
In the EC.
From Moparthi, should also increase the OSSAPCON contribution from Vijayawada. So 3,000 rupees is proposed by Uday Kumar sir, and 5,000 rupees proposed by Atmaram. 4,000 rupees proposed by sir.
No, my contention is, we have been collecting 2,000 rupees.
Yes, sir.
Suddenly we cannot make it 4 or 5.
Exactly, exactly.
So our mentality, what are the mindset of entering? Slowly increase it. In another 2 years, I think we can make it 4,000.
So shall we do it? Shall we do it like we keep it 4,000 rupees if he is becoming member of only OSAP? If he is becoming member of IOA and OSAP, 3,000 rupees.
No, don't mix that. It will be confusing again.
No, it is only 1,000 increase, sir.
Yeah, no, that will be automatically done. So that is all.
Automatically will be done.
So in spite of so many, sir, and Neno membership chairman understanding
You are really. I mean, you have taken a lot of pains.
Subramanian sir, whatever the 160 members enrolled this year are purely the contribution of Vinod Kumar sir. I should make it on record. This is purely his contribution.
Yes.
And his own effort,
Yes,
calling every EC member of all the institutions and all the teaching in hospitals to making the PGs to do that. I think he
traveled personally.
Yeah, he knows the intricacies of that.
Appreciate this.
Because the problem is to become IOA, because the subspecialties have come now. So Arthroscopy Society, Arthroplasty, there are so many societies that come now. Earlier it was only OSAP, only IOA. So people are more interested in the subspecialty associations, not for the parent associations. So that is the reason I have traveled to almost 5 to 6 medical colleges to convince the faculty and PGs to become members. So just take the ratio of how many members are joining. Even Prakasham, even POA also, there are not so many of the are members of the association.
Yes, I know.
Even in POA.
Yes.
Sir,
So
other associations had
so
made, if you want to become IOA member, you should become first OSAP member.
That is always there. That's why you need not do anything for that.
So
that's automatically they have to become OSAP member.
IAS and Arthroscopy.
You can't make it 4,000. Again, put a link to the IOA. That's not correct. Make it 3.
What the proposal?
Make it 3, and then make it 5. 5 is already there in IOA. Always they will become IOA member, OSAP members simultaneously. That is all depends on the local club presidents.
Yeah.
How they motivate their members. We have to tell them what the advantage of being a member of the OSAP, what the advantage of being a member of the IOA, what are the privileges and benefits they are going to, nobody knows. They are not being communicated properly. So somebody has to take the lead and motivate the youngsters. So otherwise they don't join us.
Yeah.
And ఎందుకు చెప్తున్నారంటే ఇక్కడ it's not the question of money. 4,000 or 5,000, whether it is big amount or small amount, it is not the question at all. Our primary aim is to encourage the enrollment. Our attitude, whenever it is 2,000, suddenly it increases 4,000, the people will have a different idea. And being a institution professor and HOD, I know the mentality of the most of the people, even the assistant professors are not interested to join in OSAP. The reason ఈ టైప్ మెటీరియల్ సైంటిఫిక్ సెషన్స్ అన్ని చోట్ల జరుగుతున్నాయి స్పెషాలిటీస్ వచ్చాక. ఇది ఓన్లీ ఫర్ ఏ గ్యాదరింగ్ లాగా జరుగుతుంది. కాబట్టి ముందు మనం ఎంకరేజ్ చేద్దాం మెంబర్షిప్. తర్వాత నెక్స్ట్ ఇయర్ ఇప్పుడు ఒక 2 years తర్వాత 3 years తర్వాత యూ కెన్ ఇంక్రీజ్ టు 4,000, లేటర్ ఆన్ 5,000.
సార్ 3,500 ఓకేనా?
వరప్రసాద్ అసలు మెంబర్షిప్ మన OSAP నుంచి అవేర్నెస్ తక్కువ. అసలు ఎంత ఫీజో తెలియదు. ఇఫ్ యు స్ట్రైట్ అవే గో అండ్ ఆస్క్ ఫర్ 4,000, it is not a big, they know that is 2,000, then only it is a problem.
తెలియదు అనొద్దు కానీ పక్కనోడు అడుగుతాడు ఎంత నువ్వు కట్టావు లాస్ట్ ఇయర్. కాబట్టి
ఓకే సార్, కన్సెన్సస్ 3,500 shall we keep? Yeah.
Okay, carry on.
So
3,000, 5,000.
It has been somebody note down the minutes please. It has been proposed to increase the membership fees to 3,500 rupees, proposed by Uday Kumar sir, seconded by Dr. Varaprasad sir. ఒప్పుకోండి సార్. Okay, so we'll go ahead with 3,500 rupees as general body agrees. Next is report of OSSAPCON 2020 by Dr. Vasu Karlapur. So we missed this report in Anantapur because that was a virtual meeting. I requested Dr. Vasu Garu to come and present the report of Vijayawada OSSAPCON. Sir, please.
Good evening, all the members, seniors, and finally the dignitaries on the dais, and especially to Naresh Garu for asking me to present OSSAPCON 2020 report, as we missed in Anantapur because of the pandemic. So all of you know, and most of you are present, I believe. It was held in Vijayawada on Jan 31st and February 1st and 2nd of 2020 by Vijayawada Orthopedic Society. And it was held at Venue Convention Center with the total registrations of 720. And we had PG registrations of 180 members. And under the chairmanship of Dr. N.S. Dattagaru and our presidentship of Dr. M.J. Naidu Garu, and as organizing secretary myself. And we had a 2.5 day, almost 3-day program. Day one is Dr. Ethirajulu Memorial CME, wherein periarticular fractures and current concepts was discussed. And we had live surgeries on trauma, arthroplasty, spine, and arthroscopy. So they were very fantastic. And live surgeries were performed by Dr. Naveen Thakkar, complex IT fracture, arthroplasty, primary TKR by Dr. Jagdish, and spine by Dr. Naresh Garu, arthroscopy by Dr. Sachin Tapasvi. And day two, we had scientific sessions, the day-long program on trauma, arthroplasty, arthroscopy, spine, pediatric trauma. And we had special session on scientific writing headed by Dr. Sham and Dr. KB Srinivas. And we had eminent persons, Dr. Lalit Maini and Dr. Raju Vaishya, who are of the international faculty. And also some aspects of cold orthopedics is also covered. And we had a PG quiz. And we had a motivational talk on obesity decoding by one of our colleague from Hyderabad, Krishna Kiran Echampati. And day three, there is a separate session on pelvic trauma, which is headed by Dr. Venkatesh Garu. And we had a cadaveric workshop on periarticular trauma. And it was done very well, and it was very well appreciated also. And some of you might have attended that. We had international faculty of 6 members. By name, Dr. Srikanth from US, Dr. Venu Kautarapu from UK, Fofansa from Bangkok, Dr. Ramesh Shankar, Dr. Arathila Murthy Garu, and Professor Francis from UK. And we have a good number of national faculty, about 35 of them, of which Dr. B. Shivshankar, who is our past IOA president, who was also there today here, and present president, IOA president, Dr. Ramesh Sain, and President-elect Dr. Atul Srivastava, Dr. Vijay Raghavan, Dr. Gurva Reddy Garu, who has done his oration, Dr. G. Narasimha Reddy Garu oration, and Dr. S.P. Mohanty from Manipal. He also has done Dr. Vagreshwaradu Memorial oration, Dr. Krishna Garu, Dr. Jagdish Menon, Dr. Ram Chadda, Dr. Sachin Tapasvi, Dr. Amit Ajigankar, and Vivek Trikka from AIMS, and Vasudio Gadagon. So all these eminent people were there in our conference in 2020. And we had Vagreshwaradu gold medal papers, 6 in number, and Dhanvantari silver medal papers of 7 in number. And we had free papers of 130 in number. And we had a good number of stalls, about 95. So this is the salient report of OSSAPCON 2020. And we are proud to announce that it went out very well, a good number of gathering, and all of you have enjoyed. And after that, we have formulated many things, but due to pandemic, I think little bit slow. And we like to announce some the contribution to OSAP after our OSSAPCON 2020. And I request Dr. M.J. Naidu garu, our VIS president, to please come on, and other members also who are there to please come to the stage with the permission of the chair and EC. Please come on to the stage, sir. We'll just hand over to the OSSAPCON body.
Thanks, sir. We'd like to know the amount also, sir.
Cheptan, sir. Laksha 25,000 istunam, sir. And Dr. Moparthi, who is our joint secretary now, was the joint organizing secretary who assisted in us, and all our members who are there. Venkatesh garu, please come on. So once again, I thank OSAP for making us organize such a beautiful conference, and we promise to do many more in future. Thank you.
President garu. Thank you, VOS, for the contribution. So there was a discussion in the EC, how much should be the contribution? Is it depending on the profit they make or the percentage of collection of the conference? How should we uniformly formulate how much to be given to the organization? So as I mentioned to you previously, this is the only source of income by which the association runs. There was some proposals that we should increase and fix the fixed guidelines for contributions. I think EC will form a committee. How much is the expected amount? Few people has quoted the 10% of the collection, and some said fixed 2 lakhs and fixed 3 lakhs, something like that. So we need your inputs how to fix the contribution to the OSAP from the OSSAPCON organizers. Unicompartmental sir, I think you are the best person to say how is there any rule or formula how to contribute? Sorry, Mike.
There was no rule. It is all depends on the profits they make. They made rather.
Yeah.
So వాసే అనుకోకపోతే విజయవాడ ఇంకా ఎక్కువ ఎక్స్పెక్ట్ చేస్తాం మేము.
సో వాళ్ళు మిమ్మల్ని కంపేర్ చేస్తున్నారు సార్, వైజాగ్ ని బట్టి మేము ఇచ్చాం, వైజాగ్ అంటే ఎక్కువ ఇచ్చాం అంటున్నారు. దట్స్ ద స్టోరీ స్టార్ట్స్ నా.
ఓకే, అంటే వైజాగ్ తో వచ్చే ప్రాబ్లం ఏంటంటే కరెక్షన్ కంటే ఎక్స్పెండిచర్ ఎక్కువైపోయింది మాకు. సేమ్ ప్రాబ్లం. అవునవునవును, వీఆర్ పార్టీ ఆఫ్ ఇట్ నో. అదే జరిగింది ఇక్కడ కూడా.
So Tirupati gave 2 lakhs, sir. After that, Vizag gave 1 lakh, and then the Vijayawada is 125. We thought
I think we can fix it at 3 lakhs.
3 lakhs for whoever is going to take next. 3 lakhs minimum or anything more?
No, not more. You said minimum 3 lakhs. Sir, what do you say, Vasu? 3 lakhs next conference nunchi 3 lakhs minimum contribution.
Minimum, some minimum
it,
contribution.
Depending upon the profit they made, some percentage.
Profit always is a loss only, sir. How can you say the how profit?
Sir, that we decided in the అంటే పెద్దల సమక్షంలో ఇందాక ఈసీ మీటింగ్ లో మీరు లేరనుకుంటా. 10% అని మహారాష్ట్ర వాళ్ళు చెప్పారు, కానీ మనం కండక్ట్ చేయలేము, మనది ఒక చిన్న స్టేట్ అయిపోయింది.
మనం మహారాష్ట్రతో కంపేర్ చేసుకోవడం Let us not compare the
No.
Maharashtra and Tamil Nadu.
So we are not
Please.
going with the percentages, sir. A fixed income, fixed
Tamil
amount,
Nadu, Maharashtra,
say
totally.
Decent గానే ఉంది సార్ 3 lakhs అనేది.
3 lakhs decent.
So I think that should be a justifiable amount.
3 lakhs
So మిగతా వాళ్ళు కూడా స్టేట్ అంటే డిస్ట్రిక్ట్ ఆర్గనైజేషన్ హెడ్స్ ఎవరన్నా ఉన్నా లెట్ us ఆస్క్ సార్ గుంటూరు నుంచి సార్ వాళ్ళు ఉన్నారు కదా ఒంగోలు కూడా ఉన్నారు సార్ అది డీసెంట్ గా ఉందనుకుంటే we can go with it from next time we'll fix it. I think
So they have to check the accounts again. They will say the same answer. So let the banquet finish.
So compare them there దీంట్లో that all depends on the collections and
Sir,
profits they make.
మీరు చెప్పేది నెక్స్ట్ టైం నుంచి కదా సార్ ఈ కాన్ఫరెన్స్ సారీ అంటే వాట్ ఐ మీన్ టు టెల్ యు ఇస్
Of course for the next time, next year only.
బట్ స్టిల్ వాట్ ఎవర్ ఇట్ ఇస్ సార్ ఇదివరకు లాగా ఫార్మా కంపెనీస్ నుంచి అయితే అంత ఈజీగా అయితే లేదండి.
We know.
సో నేను చెప్పేది మనం ఇవ్వాలి అనుకుని వస్తే తప్పించి అది రాదు సార్. సో రెండో పద్ధతి ఏమిటంటే ఒక ఫిక్స్డ్ చేయటమే దానికి అనుగుణంగా అంటే దట్స్ ద ఓన్లీ వన్ వే వేర్ వీ కెన్ గెట్ కంట్రిబ్యూషన్ టు అసెట్.
ఇక్కడ ప్రాబ్లం ఏంటంటే the cities like Guntur, Vizag and Vijayawada, Ongole, these people can give up to 3 lakhs. But we have to encourage other areas of the state where the income is very, very less. And as is rightly pointed out, the companies are not at all coming forward nowadays. That's why the organizing secretary and other team is taking a lot of strain to raise the fund. That's why one of our treasurer last time, why he is asking for the enhancement of OSSAP membership, that is one of the reasons. But there are some hiccups. Anyhow, if it fixes 2 lakhs, that is not a big burden. If the people from Kannur or Kadapa, Anantapur, where the income is very, very less, they come forward and take over the next conferences like that. If the organizing committee of that particular conference is generous, having a lot of income or if some amount is there, they can afford at least 3 or 4 lakhs. That depends upon the organizing team of that conference. But if you make it 2 lakhs, other areas, backward areas also come forward. This is my opinion. I think 2 lakhs is acceptable. That is
one stall amount, sir.
Whatever it is. Stalls also not coming, Naresh. They are not coming with very big amount.
I agree with Varaprasad. Same.
Yes.
Because if you fix the amount, it is maybe little bit easy for the Vizag or Guntur and Vijayawada people. But nobody is coming forward to conduct the conferences in other places. If you fix this amount like this, nobody will come forward.
No. So I don't think organizers are not coming for donation purpose. 2 lakhs is 2 lakhs or 1 lakh. We never proposed. We never asked for money.
Only thing is, because of all these problems, financial problems only, they are not coming. Because
to conduct the meeting, yes.
To conduct the conferences, state conference. So don't make it mandatory, or if you wanted to make it mandatory, not more than 2 lakhs.
Yeah. Thank you, sir. It has been unanimously approved by GB to fix the contribution money to 2 lakhs proposed by Dr. Uday Kumar Garu, seconded by Dr. Varaprasad, sir. Sir, okay na? Isari?
Sir, Naresh, sir.
Yeah.
Actually, we should appreciate Ongole people for taking this conference. Really is a big applause for them.
Yeah. So we have the appreciation.
Yes, it's a big applause because so many big places are there in Andhra Pradesh. They took Ongole really Jaishekhar Garu and Malyadhar Naidu Garu, which is a big thing.
Harish.
Yes.
What if the organizing body incurs a loss? Do they have to pay 2 lakhs from their pocket?
Yeah, that's the problem. No? So if they incur a loss, then there are exceptions, and then they can express the thing, and then so it is not a rule. It's a contribution fixed at 2 lakhs. Before bidding for any conference, they should be knowing that at least 2 lakhs they should make profit to give it back to the association.
Okay.
Rest of the amount can go back to the organizing association, whatever is doing. But at least 2 lakhs, if it comes to the parent organization, that will be good. In the given scenario, I think that is a very reasonable amount proposed by our seniors.
Okay, thanks.
Thank you. So next is the OSSAPCON 2021 report by Atmaram. So Dr. Atmaram sir just left, and then he sent me a message. So it was a hybrid conference conducted both physical and virtual meeting. We had 590 registered delegates, speakers from all over the globe, from different national and international speakers. We had 2 orations were conducted successfully, and the cultural programs and the inaugural sessions were conducted excellent. So that is the small brief report from OSSAPCON 2021. So if any of the Anantapur people are around here, they can also express their feelings. So next is the report from OSSAPCON 2022. Ongole, Dr. Jayshekhar, so present registration strength, delegate strength, and so no need to give contribution.
Respected President OSSAP Durga Prasad Garu, dignitaries on the dais, off the dais. Initially, I want to thank OSSAP for giving us permission to conduct. Of course, it's a daring step that we have taken to conduct a conference, a state conference like this. But with the meager 40 people in complete district, only around 25 to 30 people, majority are practitioners in Ongole. Of course, definitely all the senior peoples like Uday Kumar Garu, Amarnath Garu, and many others. Of course, our MJ Naidu Garu, Kaleshawali Garu, వీళ్ళందరూ కూడాను రియల్లీ లేదు కానివ్వండి మీరు చేయండి మీకు బాగా చేయగలరు అన్నట్టుగా వాళ్ళు ఇచ్చిన ఎంకరేజ్మెంట్ తోనే డెఫినెట్లీ వి హావ్ టేకెన్ ఇట్. అయితే మాకు మధ్యలో వచ్చిన అఫ్ కోర్స్ ఎవ్రీబడి నోస్ ద పాండమిక్, దానివల్ల చిన్న చిన్న ప్రాబ్లమ్స్ ఫేస్ చేశాము. లక్కీలీ పాండమిక్ హెస్ కమ్ డౌన్ అండ్ వీ హావ్ అగైన్ డిసైడెడ్ దిస్ డేట్. అండ్ అఫ్ కోర్స్ ఒకటే ఏమిటంటే అది బ్లెస్సింగ్ ఇన్ డిస్గైజ్ అనాలో ఏమిటో బయట ఉన్న ఎండ. బికాస్ ఆఫ్ దిస్ సమ్మర్ హాల్లో ఎక్కువ మంది ఉన్నారు, దానికి ఒక రకంగా నేను సంతోషపడుతూ ఆఫ్ కోర్స్ సూర్యుడికి ధన్యవాదాలు చెప్తూ, డెఫినెట్లీ ఇనిషియల్ గా మేము చూస్తే చాలా తక్కువ మెంబర్షిప్ డ్రైవ్ ఉన్న పరిస్థితుల్లో ఎగ్జాక్ట్లీ అబౌట్ 1 month బ్యాక్ కూడాను ఉదయ్ కుమార్ సార్ బాగా తక్కువగా ఉంది, మీరు కూడా అడ్వైజ్ చేయండి, మిగతా వాళ్ళకి చెప్పండి అనే పరిస్థితి నుంచి టుడే, as on today, senior citizens have reached about 9 members and delegates 385, PGs 180, faculty about 102, and non-orthopedicians 88, and altogether till today it is 764. And really I thank all the OSSAP members, senior colleagues, all the teachers, everybody. Without your help, definitely this number will not be there. Even though we are trying to do this, but without this number, మాకు చేయాలని ఉన్నా కూడాను మీరు అందరూ వస్తే మేము కూడాను ఎంతో సంతోషంగా చేయాలనే ఉద్దేశంలో we have done it. And luckily till now everything has gone well. And ఇవాళ నైట్ బ్యాంక్వెట్ కూడా ఇంకా బాగా జరుగుతుందని, with this definitely ఈ కాన్ఫరెన్స్ సక్సెస్ఫుల్ అవుతుందనే ఉద్దేశంతో of course మాకు చాలా సంతోషం వేసింది. విజయవాడ ఆల్మోస్ట్ 90+ ఫార్మా స్టాల్స్ వచ్చాయి. హియర్ we could do about pharma companies about 30, implants and instruments companies about 15, total about 45 stalls. Of course, చివర్లో ఇనిషియల్ గా about 15 stalls ఉన్నాయి. Last, to tell you frankly, we have given for 10,000 also one day prior to that. Of course, mainly to encourage them coming. Anyway, e-posters, initially they said 100+, but they have come out with only 67. 3 papers till now, they have come out for 97, and we have organized a PG quiz for, quiz for PGs also. Of course, we are organizing arthroscopy workshop with the natural meniscus. వీటన్నిటితోటి డెఫినెట్ గా సీనియర్స్ యొక్క బ్లెస్సింగ్స్ తోటి వీ కుడ్ డూ దిస్ అని చెప్తూ మాకు అవకాశం ఇచ్చినందుకు మరొక్కసారి OSSAP కి మీ అందరికీ ధన్యవాదాలు. థ్యాంక్ యూ.
Thank you very much, sir. But when I went to the stalls, industry stalls, the stalls all seems to be very happy in terms of business. I think this Subramania Rao sir has gone there, and So you are visited the stalls.
President Dr. Prasad, Durga Prasad has visited and taken a feedback because after a gap of 1 or 2 years, there is a physical meet and the stalls all are happy with their business, which has they received during this conference.
Instrument business you are trying.
Yes,
to say.
both.
Implants
Yes, sir.
and instruments.
Implants and business.
Oh, that's one good thing. I think you can provide us for better contributions. Thank you, Dr. Jayashekhar, sir. Now for 2023, as of now, we have not received any bids for 2023. Anybody from general body, any district orthopedic association to propose bids for 2023 annual conference? Sir, Isaac Mali chestara? Yeah. So if no other bids, then Guntur is interested or forced to be contacting. I request Dr. Naran Dogar, Dr. Ram Prasad. Ram Prasad, Nuve, Secretary of Guntur Orthopedic Association. Naran Dogar, sir, Naran Dogar, sir. Yeah. So if official proposals.
Not from the medical college side, from the
Yeah. From Guntur. If there are no objections, Guntur Orthopedic Association is interested to conduct 52nd annual conference of OSAP. So you want to say a few words? The next is the midterm CME report by Dr. Ram Prasad. So we had a midterm CME conducted under the presidency of Dr. Subramanya Rao sir. At Guntur Orthopedic Association, I had the privilege of conducting mid-year CME of 2022. The organizing secretary, Dr. Ram Prasad, secretary of Guntur Orthopedic Association, to give the brief report of mid-year CME 2022.
Respected seniors and dignitaries on the stage, me, Ram Prasad, Secretary of Guntur Orthopedic Association, had the privilege to conduct the mid-year CME program in the month of December 2021. And the topic of the main topic was the periarticular fractures around distal femur and proximal tibia, and all the lectures and everything was concentrated around these topics. And we had registration of around 70 delegates, and we had faculty all over the state, and we had almost 16 sessions, and we had steamy panel discussions with case scenarios as well. And to be frank, it was a very successful small CME conducted at KRR Mohan Rao Hall at Gymkhana Auditorium. And that was, I think, the first physical meet proposed from our Guntur Orthopedic Association as well as the activity by OSAP. And I hope that meeting was all successful. And now I think we, on behalf of Guntur Orthopedic Association, again take the privilege to conduct the next year OSSAPCON conference and hope for the best. Thank you for giving me this opportunity, sir.
And I request Subramanian Garu to conduct mid-year CMA this year.
So I request Dr. Subramanian also come on to the dais to get appreciation certificate, and also Ram Prasad to receive the appreciation certificate for mid-year CME. Please come on to the dais. Certificate.
This year, mid-year CME, definitely I'll do it at Kadapa. Theme and then concept, everything will be decided in future and I'll let you know. I think time, I mean, which way, month, date will decided by the EC and then we'll do it at Kadapa.
Yeah.
I request all the members to, in fact, I could not do it in way of my personal commitment. So I was supposed to do it in the last year itself. But because of my personal things, I could not do it. This year, definitely, mid-year CME will be at Kadapa. Thank you. I cordially invite all the members to come to Kadapa and make the program a grand success. Thank you, sir.
Thank you. Thank you very much, sir. So now we have a short report of OSSAP Cricket Premier League started this year. I request our Executive Committee member, Dr. Leela Prasad, who took the initiative to present the OSSAP Premier League.
Good evening, dignitaries on dais. Good evening, seniors and colleagues. Though primarily OSSAP is an academic body, some random idea to organize a cricket tournament, just it was like a spark in my thoughts, and somehow we felt that we could give it a try, and that is how this was born, when history was destined. This is how the OSSAP Cricket League was born. The first time in the history of OSSAP. So the first time in the history of OSSAP, the OSSAP Cricket Premier League. So just getting the idea is not enough. Making it happen, taking all the efforts to making it happen, that's more important than getting the idea. We get number of ideas, but to making the idea fruitful is more important. So that is how we formed a WhatsApp group. And this is probably the first message on the group. How about having a cricket tournament for all of us? And this was the first message in the group. And Dr. Ram Prasad replied with a thumbs up. And that is how it went off. So immediately we realized that we couldn't do it on our own. So we asked the help of OSSAP. We wanted to do it under the banner of OSSAP. So we asked Naresh about it, and Naresh immediately took the initiative. And Durga Prasad sir had immediately given the affirmative, and he has encouraged us to go forward. And that this is probably the first step forward. So we finally decided, and this is our first flyer. So taking responsibility of others means to be selfless. We have to put aside our own well-being, our own desires as secondary, and think primarily of what is best for the persons who are looking up to us. So there is one man who took up the responsibility, one place who took up the responsibility. No words can describe the efforts, no words can describe the hardships faced. So all the cricket teams, all the players, we immensely thank Guntur, we immensely thank Ram Prasad, who have taken up this initiative. They have owned this. So that is why they were able to do so well. And once again, no amount of words can thank Guntur, and no amount of words can thank Ram Prasad. Thank you guys once again. You really made it happen. And we really made it from the bottom of our hearts. So this is how the show starts. So our president, our secretary, our dynamic Amarnath sir, our president-elect Narayan Rao sir, and whistling away and letting free the balloons. This was in the JKC grounds. They are giving their words of wisdom. See all the captains, myself, Ram Prasad, Santosh, Jeevan, the teams, Prakasam, though there were only 40 members in this district, 12 of them would come and play cricket. That's a real achievement. So even though we had about 150 members, to get 12 players, it was very difficult. We had to literally నిజంగా బతిమాలాల్సి వచ్చింది అందరినీ రండి రావు. But with just number of 40 orthopedic surgeons in district, 12 players could come to play cricket. That deserves a real applause. You made it, guys. Then the Guntur team, Vijayawada, and of course our team. The first day we had 4 matches, two matches in JKC and 2 matches in Periprostic, and some picks from the day's action. These were the matches in JKC grounds. So there were only 4 matches on first day, but the spirit of cricket is infinite. On the second day, morning session, we had 2 matches. One was Prakasam and NAOA. The other match was Guntur versus Vijayawada. And one final on this Sunday afternoon, where Prakasam and our team played, and we won the trophy. So we emerged the winners, and Prakasam were the runners. Winning is not a great deal. Winning is not a big achievement. So there are 2 teams. One team is definitely destined to win. So Sunday morning, we lost in the morning, we won in the afternoon. And similarly, Vijayawada lost in the Saturday and they won on Sunday's game. So winning is definitely not a big deal. But making this happen is the biggest deal. So the true champion, sorry. So though we won the cup and Prakasam Arenas, there's only one true champion. The true champion is none other than Ram Prasad. So he deserves the trophy. Once again, big applause to the guy. So the tournament ends and we shall come back much bigger, much stronger, and much better. So we have discussed about this in the EC, and we have decided to make it an annual event. Just like we have OSSAPCON every year, we are going to have OSSAP Cricket Premier League every year. So it will be OPL every year. It will be an annual event, and we are planning to increase the participation, see that all districts participate. If the district has less number, then probably we'll club 2-3 districts together and form a team, preferably in January before the conference. So the weather is cool, and it's mostly holiday season types, and practice also a little dull, and no rains. So probably January is a preferred season. And like for conference, we have a bidding for the host. Probably we'll be having a bidding for the host as well. And so everyone, and preferably we like to have it in the center of the state, maybe Guntur or Vijayawada. And regarding sponsor also, we are trying to work out an action plan. And with our secretary's dynamism, I'm sure we'll definitely find sponsors for the event. Thanks again. Thanks everyone. Special thanks to Guntur Orthopedic Association and Ram Prasad. Thanks OSSAP also for owning up this and making it an event. Thanks everyone.
Yeah, okay. Thank you, Leela Prasad. I think there are certificates for best bowler. The best bowler of the series goes to Dr. Kondal Rao from Chirala. And the best fielder is Harsha. Best fielder is Harsha. Hey, Kondal Rao. Yeah, Kondal Rao can come and collect the certificate. Best bowler of the series. Harsha is around. Yeah, our best. Thank you, Kondal Rao. The best fielder is Dr. Harsha. I think Dr. Harsha is not around. The best batsman is Dr. Jeevan CH, and Jeevan is gone to the banquet hall, I guess. And the Man of the series goes to Dr. Jeevan again. So congratulations to, if somebody can, yeah. So Harsha certificate, anybody wants to collect? Yeah. There are the medals for all the winners. I think off the music, they can collect the things. So there are a few small agenda left, very quick agenda. We had a OSSAP BIOS International Fellowship, which was initiated after Vizag conference. Santosh, yeah, please come. After Vizag conference, but due to COVID, we have selected the candidate where it is a mutual exchange fellowship, in the sense like our candidate from AP goes to UK, London, where he gets trained for a 6 months program. So this is a mutual agreement with the British India Orthopedic Surgeon Society and OSSAP. Unfortunately, due to COVID and travel restrictions, we were unable to do. Once the first candidate goes in, then we can start as a series of annual program and annual event. OSSAP Golden Jubilee Excellence Awards, we already discussed in the inaugural function, and OSSAP research grants. So till now we had 3 research grants awarded, but none of the research grants have come to the final stage of submission. So we request the previous winners to complete the projects. And this year we have received only 1 application, and that gets the award by Dr. Professor Amarnath. EC is going to discuss with Dr. Amarnath to formulate and slightly modify the proposal to get it from the OSSAP side. OSSAP monograph editor's report. We have KBS here. KBS, yeah. Want to say something about OSSAP monograph? I think Dr. Amarnath sir has sent a message that he is going to have a case series again next year, in addition to 1 more volume of OSSAP. And Johnson is going to support for the future monographs as well. And IOA matters, we are happy to say that our state has won the bronze medal for Best Chapter Award. And this is a very prestigious award. Previously, we were never in the picture. We were never seen in the national scenario winning the medals. And we are happy that the contribution of our members and the activities of the association is bringing to the highest level. And also at this juncture, I want to make it on record. The contribution of Dr. Uday Kumar sir in making the membership for the past 3 years is tremendous. And it's a singing man's, he's working like a war to make it's a man on mission to make everybody a member. Sir, please keep on continuing, sir, even though you are not as a state representative, but we need your service as a PG teaching committee member of IOA. We always close to all the heavy heads of IOA. Please carry on the same thing, and we will see 200 members next year. This year we had 160. We want to have 200 next year. So the Dharmarao, you are the Atma Lokate. Everything goes to Vizag only, whatever you do. Thank you very much, sir. Seriously, it's a great effort from your side. And so there are one proposal to have a OSSAP medical legal self-formation. So this is a mandatory thing which is kept by IOA to get marks in the branch medals. So EC will discuss and formulate a committee and come back to the next general body meeting. So if there are no other issues, I'll ask any other matter with permission of the chair. Any members want to raise any issue? Dr. Samiran Jatra, Dr. Mrudula to speak. Want to use the mic or come up? Yeah. Yeah. So before Mrudula takes over, we just missed to recognize the services of our past treasurer, ever smiling Dr. PSB Srinivasulu. So we missed you in Anantapur. We are unable to deliver the certificate. I'll call upon you to take a small memento from the OSSAP. So we had a wonderful 3 years of journey with the PSB. With whatever stress and tension you have, once you see him smiling, all your stress will go off. Such a lovely personality. PSB, please, you want to say a few words and then we'll take a certificate.
Thank you very much, sir. I thank senior professors and legendary orthopedic surgeons for giving me this opportunity to serve our association as a treasurer in between 2018 and 2021. It's a memorable moment for me. Thank you very much, sir.
We also wanted to recognize the services of our outgoing Joint Secretary, Dr. Vinod Kumar Reddy. I think he has left. We'll pass anybody from Tirupati to collect a memento on his behalf. Otherwise, we'll pass it on to him. And the medals for so come for Santosh, the winner's medal. Come Santosh. There, sir, ఇంకొక మెడల్ వేస్తే వెళ్ళిపోతారంట. All medals. So Santosh will collect all the medals for the winners of North Andhra Orthopedic Association for Cricket League. So please distribute to all the team members. Thank you. Thank you. Now we request Dr. Mrudula to propose her proposal here.
Good evening, everyone. Thank you for the opportunity. On the behalf of all the women orthopedic surgeons of Andhra, I would like to put my proposal because we women orthopedic surgeons, we are still in our infancy. We need a lot of nurturing. We need a lot of support and mentorship from all our seniors. We have already formed a group for ourselves. Currently, we are 80+ members and helping out each other, and still 30+ members data is still yet to be received. So on this juncture, I would like, it would be nice if we form a OSSAP women's wing, and would like to have a separate women's session in the coming conference. Thank you.
Bhavani sir, yes sir, please. So proposal by Dr. Mrudula to have something for the women orthopedic surgeons. Audible sir.
With the permission of the chair. Actually, it is of OSSAP following some tradition for the last few years, who is conducted as our organizing secretary was in the coming subsequent years, we are proposing as elevating as president-elect post. So last 2020 OSSAPCON organized, VOS organized that conference. I request the OSSAP Executive Committee to utilize the service of the Dr. Vasu Karlapudi in the near future. That's what a proposal from VOS.
Sure, sir. There is a procedure which we all follow. So we all love Dr. Vasu Karlapudi. If he is interested to contest for the president post, sir, for the president post, please file the nomination. We try to, please.
Sir, just a small correction. What actually Vaipun Chandra Garu is not here. He asked me previously, the district organization which used to conduct a conference, the next election, they used to be the president.
Yes.
Like before, like we started putting elections and all. So he asked us when we are in a meet in VOS, then we thought, okay, we'll put it forward in front of the GB so that whether the same thing will continue, where previously the సాంప్రదాయంగా ఇప్పుడు భవానీ శంకర్ గారు చెప్పింది కంటిన్యూ నేను కాదు నాకంటే సీనియర్స్ ఉన్నారు కాకపోతే దే ఆర్ లైక్ హెసిటేటింగ్ టు బి పార్టిసిపేటింగ్ ఇన్ ద ఎలక్షన్ సో దానికి పూర్ణచంద్రరావు గారు ఏమన్నారంటే ఇట్ ఈస్ ఏ ట్రెడిషన్ లైక్ సార్ట్ ఆఫ్ థింగ్ ఫ్రమ్ ద డిస్ట్రిక్ట్ ఆర్గనైజేషన్ సమ్ ప్రెసిడెంట్ షుడ్ గెట్ ఎలక్టెడ్ అనేది దెన్ ఐ సెడ్ ఓకే సార్ యు బీ దేర్ విల్ ఆస్క్ ఇన్ ద జనరల్ బాడీ నెక్స్ట్ టైం సో భవానీ గారు నా మీద ప్రేమతోనో దేంతోనో నా పేరు ప్రపోజ్ చేశారు స్టిల్ ఐ ఆమ్ నాట్ దట్ ఫర్ దట్ పోస్ట్ బట్ సమ్ ఆఫ్ అవర్ సీనియర్స్ ఆర్ దేర్ ఇఫ్ ద ట్రెడిషన్ ఇఫ్ యు ఆర్ విల్లింగ్ అంటే లాస్ట్ టైం నారాయణరావు గారు కలిసినప్పుడు కూడా సార్ మీరు ఉండటం మాకు చాలా ఆనందం నెక్స్ట్ టైం మా వాళ్ళు ఎవరన్నా ఉంటే యూ జస్ట్ సపోర్ట్ us so that we'll go unanimously without any election. That's what we want to deliver in this meeting, sir. So I think my point is clear.
Yeah.
Thank you.
I got your point, sir. So we had some traditions and some rules written. So traditions we have been following. The rules says as per the constitution, we have to call for a nomination. I think what you propose is a friendly gesture. We all need to sit and formulate before filing in nominations. Maybe our seniors can put some thoughts on this. Can we, it's like automatic promotion, or should we have a nomination at all? But if anything like a major decision like this to not call for nominations has to go. Yes, sir. So we all future contestants to consider the contributions of the previous organizers. That's what we are proposing. Yeah. I understood. Sir. ఉదయ్ కుమార్ సార్
అంటే ఇది కన్వెన్షనల్ రూల్స్ అని కాదు అంటే లాస్ట్ టైం ఏమే ఇది వైజాగ్ గుంటూరు